topic is from one end of the spectrum, management of MAM and SAM revisited. We have Dr. S. Srinivasan to talk to us on this, and the chairperson is Dr. O. Jose. Dr. Jose, again, I have known him for the last 20 years. So he's associate professor at Government TD Medical College, Alappuzha. He's a national secretary of PAI and state president of PAI, national EB member of many years, and past state secretary of IAP and NF Kerala. With great regards, let me welcome you, sir, to be the chairperson of the session and also to introduce the speaker. Welcome, Joseph.
Dr. Anand.
Sir.
You are the host.
Okay, no. Sir. Thank you.
Yes, sir.
I am audible to you?
Yes, sir. Now you are audible.
Good morning to all. Respected nutrition chapter president and my own good friend, Dr. C. Prasad, State IAP President, Dr. E.P. Jayaraman, sir, National Past President, Dr. N.K. sir, Sumar, sir, and National Central Zone Vice President, Dr. Someshwar, sir, all the senior members of IAP Kerala and Nutrition Chapter, and my dear faculties and delegates. At the outset, I take the opportunity to thank and congratulate IAP Palakkad, IAP Kerala and Nutrition Chapter conducting the important webinar series on nutrition in pediatrics concerns. As you know, the malnutrition is a major threat to our community, and that is a major challenge of our pediatrician in their day-to-day practice. As everybody mentions, malnutrition, there is a spectrum of malnutrition, undernutrition, and overweight are the main issues. Undernutrition, mainly the wasting and stunting, and underweight are the major challenges in our nutrition. The growth of the child is concerned. That is how a great impact on the later half of the children is concerned. Like all, we are in the COVID era. There are a lot of vitamin deficiency and mineral deficiencies are coming up, like a vitamin D and all. Another spectrum of malnutrition is overweight and obesity, resulting in diet-related non-communicable disease, and that is have late impact on children and their later life. Globally, there are more than 33 million children are underweight, underweight are moderately malnourished, and 90 million children are severely malnourished. All the impact existing on the severe acute malnutrition and the impact on the manage, how to intervene and how to tackle with the SAM management is well established in the for last several years by the national IAP and all the WHO, and even the give correct direction to emphasizing the impact in the community has given a lot of webinar and lot of series of talks are done. But regarding the MAM, is one of the things is not much discussed in our platform, and how to tackle the moderate malnutrition in our community. That is a major threat in our communities. So the major challenges in the malnutrition, the MAM is the prior step to SAM. We have to anticipate. So if you correctly intervene the management that is MAM malnutrition, moderate malnutrition, we can prevent the SAM, and we can have higher rate of SAM mortality and morbidity we can be curtailed. So regarding the management of SAM and MAM, you have an excellent faculty, Dr. S. Srinivasan, sir. As Dr. Sukumar sir mentioned, he's from Chennai. He's a he's a state child health nodal officer in NICU and PACU under the NHM, and he is a state task force member of IAP Tamil Nadu, Kerala, and he had more than 33 years of in government service and 13 years in public health experience in establishing the pediatric management. He has established 73 SNCU throughout Tamil Nadu, which have a lot of impact on the reducing the IMR in the Tamil Nadu states. And currently is a state corona nodal officer. He has treated more than 2,000 corona positive children, including the newborn, and for the last 2 years. With this phase, I invite Dr. Srinivasan sir to enlighten us regarding what is the newer insight on SAM and MAM in the community. Welcome, sir.
Thank you, sir. Thank you, Dr. Jose. Am I audible, sir?
Audible, audible.
Yeah. I'll share. Maybe allow me to share the screen. Yeah. Yeah. Let's see. The PowerPoint, proceed. Are you able to see the screen, sir?
Yeah. Sunny.
Yeah. Thank you very much for the nutrition president, Dr. Sri Prasad, IAP Kerala, IAP Palakkad, Professor Elizabeth Madam, and many distinguished senior faculties and professors, and Dr. Athira for giving this opportunity to talk about SAM and MAM in our country. And I'm very happy to see this topic because in India, if you take our under 5 mortality into concern, the top 5 disease, especially the pneumonia, the diarrhea, the malnutrition, the measles, and malaria, out of this 5, all the 4 diseases are interconnected. If you concentrate on nutrition, I think we can bring down the IMR of India from 32 to even what Kerala is enjoying, a single-digit IMR, something like that. And more importantly, many studies have proven that nutrition especially plays an important role in bringing down 40 to 45% of the mortality, even in pediatric intensive care units. So based on this background, I think it is very important. The current trend of postgraduates, they are very happy to see many equipments like CPAP, high frequency ventilators, and other things. But still, the nutrition is one basic one. Very unfortunate to see when the PGs are resuscitating the sick cases, there are no inotropes and equipments, not thinking about hypothermia, hypoglycemia, some basic things which needs for the children to come around. So in that scenario, I think this is very important topic. So let me go with what we are going to do today. So what is the overview of management? Before going for overview of management of SAM and MAM, the India has a prevalence of 6.4% severe acute malnutrition at present. In fact, Tamil Nadu has got more number of severe acute malnutrition compared to any other. But unfortunately, we had only 6 nutrition rehabilitation centers compared to the other state. They have a lot of nutrition rehabilitation centers. We need to collect how much of MAM and how much of SAM is there in each and every district, which I'm going to do in the next month, collecting the data from each and every block through the Anganwadi system and producing a real data of how much MAM and SAM is prevalent in Tamil Nadu. So whenever you are thinking of managing the severe acute malnutrition, there are 3 phases we always think before managing the malnutrition. One is what you are going to say is a stabilization phase. Number 2 is the transition phase. Number 3 is the rehabilitation. When I say stabilization phase, any SAM child or MAM child, when they come to you with complications, without treating the complications, starting the nutrition therapy may not be very beneficial. This complication has to be stabilized. That's why it's called stabilization phase. This stabilization phase usually takes around 24 to 48 hours. Any SAM child or MAM child come to that.
Sir, you're muted. Sir, you're muted.
Muted, sir. Muted, sir. Muted. Otherwise, Anand, please unmute, sir. Anand, please unmute. Some issue with the sir, so please unmute. And Johnny, okay.
Audible now?
Audible.
1 minute, sir.
Yeah. So, treating the complications, the child will be drowsy without any appetite. This is the situation. We feel always most of the child we lose in the first 2 days during the stabilization, especially when you see SAM and MAM. This is the time you treat the complications. Then of course you do the starter diets. Here starting the starter diets, this very simple protein and calorie, good calorie, is to make the metabolic functions to act and to correct the deranged electrolytes. This starter diet is not going to give the required protein or calorie for the child. This is simply priming the child that I am starting the starter diet when the child is in the stabilization phase. Once the child goes after stabilization phase, they go to the transition phase. It may take 3 days, 4 days, 7 days, depending upon the illness. And during the transition phase, the appetite comes, child start losing edema if at all there. The metabolic functions are very active. And this is the period we can go for catch-up diets. Catch-up diet with a little bit of more protein and more calorie. And this catch-up diet is the quantity of the catch-up diet is equal to the starter diet. We are not going to give extra quantity. The quantity is going to be the same. Suppose I'm going to give, say, 7 feed per day. I will continue the 7 feed per day in catch-up diet. Then comes the stabilization phase. That is a phase. The child has got absolute good metabolic functions. Appetite is good. Edema is disappearing. Child is recovering well. Mother should be encouraged. Mother should be taught. Physical and emotional binding, everything has to improve. So these 3 phases are important in managing this MAM and SAM children. So let us see one by one what we can do for hypothermia, hypoglycemia, dehydration, dyselectrolemia, infections, micronutrient, and feeding principles. I think my slide is not moving.
Slide is not moving.
Yeah. Sweta?
Sir, you can stop sharing and then again start sharing.
Now it's moving.
Yeah. So this is what I was telling about stabilization phase, transition phase, and rehabilitation phase. So that means it takes around maybe 2 to 4 weeks or 2 to 4 weeks. But any child who gets admitted in NRC, the NRC functioning can be assessed depending upon the stay of the child. The child has not recovered in 14 days. I think the NRC may not be functioning really well. That means you have to achieve the good results by 14 days. For example, if you want to say hypothermia, hypoglycemia, dehydration has to be corrected in the first 2 days. Of course, dyselectrolemia, you may be continuing potassium and magnesium for 2 weeks. Micronutrients, you have to continue. Infections, you will give antibiotic for 1 week. And feeding, cautious feeding in the beginning, then you go for rehabilitation, you can go for catch-up growth. So how we can treat for hypothermia? Everybody knows about mild, moderate, and severe. Mild hypothermia, that is 36 to 36.5, you just cover the baby. Moderate hypothermia, 38 to 35.9, you just do the rapid rewarming, putting the child in the warmer. And severe hypothermia, most of the PGs are not knowing how to treat severe hypothermia. There are 4 cardinal principles of management of severe hypothermia in a SAM and MAM child. First, you should give oxygen, whether there is distress or not. The child should be given 10% dextrose bolus, 5 ml per kg bolus. Even you are not testing the blood sugar, don't worry. Then do the rapid rewarming. And most important, when the child has got hypothermia or hypoglycemia, always take it as a sepsis and treat with antibiotics. What do you do for hypoglycemia? Any hypoglycemia less than 54 milligram? There are 3 ways of correcting the hypoglycemia. Suppose a doctor is in district headquarters hospital or taluk headquarters hospital where he is not getting a Venflon or doing IV line. I think that can be done. If the child is conscious, then you can go for oral feeds, 50 ml of 10% sucrose. How do you make the sucrose? You take 1 big teaspoon of powder in 3.5 tablespoons of water that makes 10% of sucrose. Or through the NG tube, you can give 50 ml of 10% dextrose. The child is very sick, you can go for 5 ml per kg of 10% dextrose the first 2 hours. Then you can start doing the starter diet every 30 minutes. Then you can go for starter diet every 2 hours. Once the child has come out of the hypoglycemia. If you have hypoglycemia or hypothermia, consider a sepsis, treat with antibiotics. Dehydration. So dehydration, we always know what is something called reactive adaptation. What is this reactive adaptation? You know that even though the child is having hyponatremia or hypokalemia, Most of the sodiums are sitting inside the cells, which are not shown outside. So there's no need to correct the sodium in severe acute malnourished or moderate acute malnourished child, provided the sodium is not going below 120. As long as it is fluctuating from 120 to 130, you need not treat sodium, you treat with potassium. Since the sodium is more, there's no chance of using ORS in these children because ORS contain 90 milliosmol of sodium. Actually, the child needs what is 45 to 60 milliosmol of sodium. So best thing is go for what is called Rizomol. So you have to know the constituents of Rizomol for the benefit of postgraduates who are looking around this seminar, where glucose is 125, sodium 45, potassium 40, chloride 70, citrate 7, magnesium 0.3, magnesium is 3, zinc is 0.3, copper is 0.03, and osmolality 300. I think this is the only Rizomol solution where you can see the chloride is more than the sodium, and potassium is almost close to the sodium. So you have to treat the child with the rehydration solution for malnutrition. And we know how you to treat first 5 ml per kg every 30 minutes in the first 2 hours, then 5 ml per kg every alternate hour for 10 hours. Then, of course, you can go for maintenance of Rizomol, 50 ml for less than 2 kg for each and every stool, and 100 ml for more than 2 kg for each and every tool. And starter diet may be tried every alternate hour. That is very important in the rehydration in treating without shock. Suppose the child has got the shock, very simple, give oxygen, select a fluid of ringer lactate or off normal saline. You give 15 ml per kg and see whether the child is improving. What do you mean by improvement in SAM and MAM child? A decrease in pulse rate of 15, a decrease of respiratory rate of 5, it's called improvements. And the child shows an improvement, then you can continue again with the 15 ml per kg. You are not overloading the child because the child is accepting and improving. Then you can go for starter, then you can go for oral feeds when the child is stabilized. Suppose the child is not improving after 50 ml per kg of ringer lactate or of normal saline, then you have to go, there's no need to continue one more bolus because you will be overloading the child and child will land up. Those situations, you can go for a maintenance fluid of 4 ml per kg. And of course, you have to start dopamine and think of infection, whether to start antibiotics or not. So most of the AAE room setup where the child comes with very severe sickness in the form of cardiac failure or in the form of status epilepticus or whatever it is, many PGs tend to forget that we are dealing with the child of SAM and tend to overload these children. So this is very important whenever you are treating in an emergency room and the SAM comes, not to overload the child. Very important in SAM management, overhydration, overfeeding should be avoided. Dyselectrolemia. I told you need not treat sodium. You can treat potassium because it is called the reactive adaptation. The potassium is being lost, sodium is being retained. So you give potassium 3 to 4 milliequivalent per kg per day for 2 weeks. And the child is in the initial phase, in the transition phase, and also during the rehabilitation phase, you continue potassium. And magnesium sulfate also, which makes the potassium to come into the cells 0.3 ml per kg. Initially, on the first day, you can give in the form of IM, then you can give in the form of orally for 2 weeks. Infections. See, in SAM cells, as the unique SAM and MAM, they have the unique habit of reduced T cell immune suppression. Of course, the B cells are not much affected. That's why you can give any vaccines to this child, they can adapt to the vaccines, but the T cell is very much suppressed. But means you are not going to get the real clinical scenario from these children. Hyperthermia may not be there, and CRP may not be positive. Sometimes MAN2 may not be positive. So you always have an high index of suspicion whether you are dealing with the CHAM child, whether the CHAM child has got infection or not. That's why I said hypothermia or hypoglycemia is a sign of infection in SAM. So how do you treat meningitis? These are all the antibiotics. WHO has given very clear guideline. These are all the antibiotics you can use for SAM child. Suppose you are dealing with meningitis, ceftriaxone with amikacin, dysentery, ceftriaxone with ciprofloxacin, septic shock, ceftriaxone with gentamicin, and other causes. If you don't know the focus of sepsis, you can go for ampicillin and gentamicin. Micronutrients, I think Elizabeth Madam will be very happy to see this slide. Yes, all SAM children should be treated with micronutrients. So as soon as you see the SAM and MAM child. Vitamin A program, this is very important for all children, whether they have vitamin A deficiency or no deficiency. Suppose there's no deficiency, I think you should give prophylactic vitamin A, and based on the age, everybody knows about the national program. 50,000 units for 6 months, 6 months to 1 year, it's 1 lakh, more than 1 year, it is 2 lakh. But take it, see to that, when the child is not crossing 8 kg, whatever be the age, it should not be more than 1 lakh. Suppose you are going to give therapeutic vitamin A, give 0, 1, 14 doses. And just remember this 1, 2, 3 when you start giving the micronutrient for this baby. 1 milligram of folic acid. Of course, you can start with 5 milligram of folic acid in the first day. Then you have to give 1 milligram of folic acid, 2 milligram of zinc, 0.3 copper, and 3 milligram of iron. Of course, iron you are going to start during the catch-up diet, not during the starter diets. Then feeding. Once you treat all these complications like hypoglycemia, hyponatremia, dyslipidemia, infections, anemia, and everything, how that feeding is going to be started. You should know whether the child has got appetite or not. So there's one simple thing WHO has given what is called appetite test. What do you mean by appetite test? The mother should make a ready-to-use therapeutic feed of 100 grams. Be in an isolated room where the child cannot get disturbed. Make the child to sit in your lap and start feeding the child teaspoon by teaspoon. Some child may spit, some child may vomit, some child may take. Even though the feeding starts there, usually it takes around 1 hour for the mother to complete the feeding because the child is in the transforming phase, could not take the feed fastly. So after 1 hour, the mother should assess whether the child has taken how much of feed, whether to give pass or fail to see this child. So how to remember whether the child has passed or failed? So just multiply the weight into 5. Suppose a 7 kg child, SAM child is under appetite test. The child is able to consume 7 into 5, 35 grams of ready-to-use therapeutic food. You can give the child as pass. You can go on with the starter diet on that one, F75 and F100. Suppose the child is not consuming, then you should say the child has failed in taking this starter diet. Then you should think of giving total parental nutrition for those children. This is what we call appetite tests. Why this appetite test has to be done? Because we are worried about the refeeding syndrome. Go back to the history. What in Netherlands? What has happened in Japan? Where after the prolonged starvation, when the war prisoners were given a healthy food, many war prisoners went in for cardiac failures and died. And many people were wondering why these people who on prolonged starvation were not dying, but after giving so much healthy food, they are dying. So they found a lot of research went on, and they found that what is called nutrition recovery syndrome or refeeding syndrome. And what is happening when they take overfeeding, there is hyperglycemia. That means the gluconeogenesis is going to be curtailed. Then what is going to happen because of the rebound hyperglycemia, insulin is going to start increasing its secretions. That causes influx of potassium, magnesium, and of course phosphate into the cells, leading to hypophosphatemia, hypokalemia, hypomagnesemia. All these things are very important for the muscular contractility. So you get a cardiac muscular dysfunction leading on to cardiac failure and dying. So this is the basis for starting the F75 diet. The F75 diet is the diet which is not going to give the required protein or calorie for the child. This F75 diet is nothing but the testing diet for the child, whether the child is tolerating, whether the child is accepting. Even then, the child can have a minimum increase in weight of 5 to 8 grams per kg, provided the F75 is successful. So because of this refeeding syndrome, this F75 concept has come. Once the child accepts F75, then you can say that after 2-3 days, there is a gain of weight of 5 to 8 grams per kg per day. Then you can go for catch-up diet. That means the child can accept from 0.9 gram to 2.9 gram of protein, from 75 calories to 100 calories. Of course, you should take care of the emotional and physical stimulation also. So starter diet is always, we say 130 ml per kg. You can give second hourly on the first day, third hourly on the second day, fourth hourly on the fourth day. Suppose you are dealing with edematous child, it cannot be 130 ml per kg. It should be 100 ml per kg. And you should see that the minimal acceptance of the feed is more than 80%. Of course, catch-up diet, you are going to give 150, 200, 220 ml per kg. What is ICH is practicing when we are dealing with MAM and SAM? We always go by the what WHO guidelines says in our NRC, the starter diet. You prepare for 1000 ml so that 3 to 4 children can take. As I said, I'm going to start 2 hourly in the first day and 3 hourly on the second day and 4th hourly on 4th day. A milk of 300 ml, it could be a pasteurized milk or it could be a almond milk, whatever it is. A sugar of 100 grams and coconut oil of vegetable oil of 20 ml. Add water up to 1000 ml. And this is the starter diet, which is going to give 0.9 gram of protein and 75 calories. You can also have a starter diet based on cereal-based one, where you have a milk 300 ml, sugar 70 gram. You are reducing the sugar from 100 to 70. Coconut oil, vegetable oil is going to be 20. And you include what I have in my NRC is a puffed rice, that is 35 gram. So that you get water up to, had water up to 1000 ml. And this also gives 0.9 gram. So this depends upon the children, whether you're going for straight milk and oil diet or milk with cereal-based diet. So what is the catch-up diet we are practicing? Again, the hospital milk 900 ml, sugar 75 gram, coconut oil 20 ml, water up to 1000. This is purely WHO-based guidelines. Government of India has given a practical guidelines what to deal in NRC, which we are practicing in our NRC, which gives protein 2.9 grams and calorie 100 calories. This is what we call catch-up diet. What are the other diets used in this SAM and MAM? Especially when I see a case of MAM. The previous Dr. Jose was telling, I think you should concentrate more on MAM rather than SAM. SAM is the direct, it's going to give the directly proportional to the mortality. The MAM is going to be the indirect proportion. Unless you treat the MAM and they become the SAM, then you will be in trouble. So prevention of SAM is also an important thing. So whenever we see these kind of children, when they come in the MAM category or SAM category, what are the two diets we use in ICH? Number one is the high energy milk. That is milk with sugar with coconut oil. 100 ml milk, 1 teaspoon sugar and half teaspoon coconut oil will give 3 grams and 100 kilocalories. And there is one, what your Trivandrum Hospital got a SAT mixture, something like that. ICH has got a profound history of having this CPP kanji, cereal pulse protein kanji, where this has been done in our hospital. It has been done by our dietitian, where ragi 400 gram, wheat 350 gram, Bengal gram 150 gram, groundnut 100 gram. And you powder it, or groundnut and Bengal you powder it. Wheat also you can just you can powder it, and ragi you have to moisten it and make it sprout. Then you dry it, then you powder it. So these four combinations gives, when I give 100 ml kanji, 12 grams and 360 calories. In my ICH daily, not only NRC patients, not only nutrition patients, leukemia patients from the hematology ward, and other patients, other pulmonology ward, those who need real nutrition, where the pulmonology cases may need more than 2 to 2.5 gram per kg of protein, they get this CPP kanji from our department. So I will say maybe 50 to 100 children are getting benefited every day in Institute of Child Health and Hospital for Children because of this cereal pulse protein kanji. Of course, in our department, I see a lot of inborn metabolism coming to me. That means phenylketonuria is coming, tyrosinemia is there, MSUD is there, and we give ketogenic diet from some status epileptic children also. And these are the diet we get from some of the companies in Bangalore, where they call what is called meta-nutrition, where the concerned toxic products has been eliminated. For example, if I treat a phenylketonuria, this is called meta-nutrition PKU. If I treat a MSUD, this is called meta-nutrition MSUD. In fact, I have written to the Government of India and National Rural Health Mission to give me around 25 lakhs for treating this kind of inborn metabolism, where the nutrition therapy is the cornerstone of treating these children. Not any other drug is going to help in this inborn metabolism. So this is the one slide which everybody wants to see when you see a rehabilitation phase. You have to see whether child has got edema or no edema. If there is edema, then you have to restrict your fluid and calories to 80, potassium 5 to 7, and sodium 1 to 2. After getting treatment, if the edema is better, then you can go for the further starter diet and other things. If it is not better, then you have to revisit and see whether the diet is fine or not. Similarly, if you have a diarrhea, whether you see whether the diarrhea is mild diarrhea or severe diarrhea, it is going to be a severe diarrhea causing much of dehydration. You can go for a low lactose diet with same amount of calories. And if it is not mild diarrhea, you can just go for and see the last 4 and complete the vaccination. Gradual increase in diet should be done. Involve the family and prepare the home, so that the mother can start preparing this kind of diet in their home. And psychomotor stimulations also is very important in these children. What is the discharge criteria we adopt in our hospital for MAM and SAM? The child should be very alert and active. He should be eating around almost 120 to 130 calories per kg per day. I expect a consistent weight gain of 5 grams per kg per day for 3 days. I see to that the child is getting regular micronutrients. See to that the child is free from infection. And if the child is not immunized in the hospital or discharge. And caretakers sensitized to home care. This is very important. The mother, see, this you allow the mother in the NRC to mingle with the child. Allow the mother to take part in any management. The mother should should touch the child, should treat the child, should also massage the child, whatever is needed when there is hypotonia. The mother should give some physiotherapy also, improve the mother bonding with the child, and see to that mother is confident of handling this child. And we send back the child to the house. See, there are two important criteria. Not only see the children, see the mother, whether the mother is confident, number one. Whether the mother can handle in their house, number two. Whether the mother knows what are all the preparations, what we have made in NRC, whether she can make in the house, number three. Number four, fourth important one, whether the mother is able to identify the red flag signs in the house. Unfortunately, most of the severe acute malnourished children, after getting discharged from the NRC, they may die in the home. Or there are chances of relapse of malnutrition from the home also can come. So the mother should know whether she can identify the red flag signs. What are all the red flag signs? Whether the appetite is lost, whether the edema is appearing, is there any reduced urinary output? Is there any lethargy? Is there any refusal of feeds? Is there any progression of anemia? Is there any cold peripheries? Whether the child has got an abnormal behavior in the form of lethargy or irritability, these are the red flag signs we should teach this mother as per the IMNC guidelines. And the mother should know whether these problems are there in these children. And of course, you can have what is called teleconsultation in these children, so that we can just know how the child is going on every day. So this teleconsultation is very important. So how you are going to do a follow-up of these cases when you are managing these children? I think Anganwadi system is a very strongest system in Tamil Nadu. Of course, some other states has got Asha system where the Asha can go and visit and see these children. In Tamil Nadu, we totally depending upon Anganwadi system. In fact, Tamil Nadu has only 2,000 to 3,000 Ashas compared to any other states in the country, because our Anganwadi system is very strong. So you link the Anganwadis to these children. Anganwadi means, I say, 1,000 population, we are going to have one Anganwadi. That means that Anganwadi can have, say, 25 to 50 children in the baby registered in Anganwadi from 1 year to 5 years. So this Anganwadi should be linked with these children, and you should get the data and report from the Anganwadi how the child is progressing. And if there is any problem, the child should come back to our institute for further management. What is nutrition failure? In spite of all this management in MAM and SAM, taking care of the stabilization phase, taking care of the transition phase, taking care of the rehabilitation phase, still we see some children are not responding. That is called nutrition failure. How do you assess a nutrition failure in the case of nutrition rehabilitation center? The child has not improved with the appetite even after 4 days. Usually we say within 48 hours, once the complication is being stabilized, the child should regain the appetite. The child is not regaining the appetite by 4th day or by, say, 5th day. You should suspect, am I missing something? Is there any hidden infection in this child? Whether am I not treating the infection in this child? So poor appetite by 4th day. Persisting edema. Nowadays, I am seeing in the last 3 months, 2 to 3 kwashiorkors also. The kwashiorkor, you know why the kwashiorkor is coming. Why? There is a starvation, but one group of children goes for marasmus, one group of children goes for kwashiorkor. The kwashiorkor occurs because of the decrease in insulin growth factors. There will be a poor peripheral utilization of glucose. There will be a poor uptake of protein by the liver, goes for hypoalbuminemia. And there will be a poor fatty acid oxidation, leading to all the fatty acids getting deposited in liver and producing the fatty liver. So there are certain cases, many books say 10 to 15% of the children can go for kwashiorkor. So I get children with kwashiorkor also. So when the edema is there, the edema also should lose. There should be a loss of weight in the form of edema disappearing slightly, slowly by 4th day. And the edema is persisting even beyond 10th day. I think we are not doing justice to the children. We should see something you are missing in this child. And of course, weight gain is very, very important. The weight gain is less than 5 grams per kg per day. I think we are not doing justice. And this is very, very, very important. These 3 symptoms. And of course, don't forget the behavior pattern. The best discharge criteria for SAM children from NRC is smiling face. And the child comes to your NRC with mental apathy. They'll come to you with lethargy. The child comes to you to NRC with irritability. you start treating the child. One day, maybe 7th day or 10th day or 14th day, the child will be smiling at you. That is the best diagnostic sign that the child is ready to go home. So there are incidents of nutrition failure in spite of the effective management in the form of F75 and F100 and other diets. So we see some challenges in this nutrition failure. We have to further investigate to find out whether any other comorbid conditions is presenting in this child which is not going to be correct. And anemia also is going to be the one factor which is very difficult to treat in this type of children. These anemias cannot be given during the starter diet for simple reason of free radicals, and of course the child should not waste his energy and protein and energy for converting this iron into ferritin. Whenever you take iron, it is getting converted into ferritin. For that, you need a lot of energy and protein. Here is a child who is deprived of energy and protein, and you start iron earlier. This is going to moribund. This is going to be the moribund for the child. So always you go for starting the iron when you are dealing with a catch-up diet. That means when I say the catch-up diet, the child is consuming per feed 2.9 gram of protein and 100 calories. That is good enough and more than good enough to convert the iron to ferritin. That's why iron is not prescribed during the initial period. It should be given during the catch-up diet. So with this, I think I come to a conclusion that it's a real challenge to see MAM and SAM children in managing, especially when they come to when we have dealing with complications, especially when these children, when they are entering the emergency room. I think every pediatrician, when you are dealing with the emergency room pediatrician, intensive pediatrician, always have some mind about, think about SAM and MAM, where the aggressive fluid is going to cause problem to the child. So I thank the Kerala Palakkad IAP for giving this opportunity. I hope I finished my talk in time. Thank you very much.
Thank you, Srinivasan sir, an excellent narration and revisit of SAM and MAM is concerned. So there are a lot of queries are there. We'll take a few questions because we are running short of time. So one doubt, sir, is the criteria for SAM and MAM as only the anthropometric criteria to differentiate between MAM and SAM is there. So the management of or MAM or SAM, the stabilization phase and starting feeding phase are same as SAM and MAM, or any difference between MAM and SAM?
So there is a definite difference between the MAM and SAM. I don't see MAM cases are coming with a lot of complications. This the early identification of MAM is very important. In fact, most of my hospitals, we miss the MAM. We miss many MAM. But because the child is walking around, child comes with bronchiolitis and goes, child comes with bronchopneumonia and goes. So because it is the PG should have a duty of all children should have a WHO growth chart. You should see the weight for age and height for age and weight for height for all the children. Then only we can detect MAM. So what so far I was discussing is completely SAM, which has been managed in our NRC and in our ICU. Usually MAM children, they don't come with that much of complication, but identification of MAM during the illness is very important so that they may not go for SAM. So this criteria of stabilization and transitional rehabilitation more in favor of SAM, not for much of MAM.
Thank you. Whether this Risomal is available in Kenya or in India level?
Risomal is now not available, sir. What we do, we know the indigenous way of making the Risomal. So what we do, take 2 liters of ORS, 2 liters of water and 1 packet of ORS and add KCl. We may not be having the micronutrient, what I was telling, the zinc and copper and manganese, but you can have a good potassium and sodium. By having 2 liters of water, this 90 milliosmol will come down to 45 to 50 milliosmol. So best thing is have ORS, put it in 2 liters of water, add KCl. That is Risomal, indigenous way of making Risomal.
So another query is whether I need to add cereal to starter diet for oil to mix properly. Otherwise, if oil would be raised to top of the feed. Is it queried by one?
I think adding oil. You are asking adding oil? Yeah. So this is what the WHO guidelines are. When you start F-star, see, I have seen many children, when I give high energy milk, what you said is, yes, some children, they may not tolerate. So what I do initially, we go with milk and sugar, then slowly increase the calorie by adding the coconut oil. But F75 vegetable oil is a must. you should give 20. Fat is a real, you should give fat in these children when you're starting starter diet. So 20 ml in a 1000 ml is not that much, which will not cause much problems.
Indigenous prepared supplements are less in energy, in protein, electrolytes, and macronutrients compared to the classical RUF. RUSF. So another query is say any recommendation for Amardam body. Is it available in Tamil Nadu? Here is Amardam body, sir.
No, it is exclusively for Kerala, sir. Tamil Nadu, of course, people will go a lot of things called manna mix, where 12 to 13 ingredients are there. Nowadays, people started having all those things. But as you said, many sweet stalls like Krishna Sweet Stall and Grand Sweets, they have come up with a lot of nutritious powder for the children. They have their own scientific formulas on promoting. But it is not proven so far whether we are giving an adequate level for all these children. So generally, in my clinic, most of the children, I advise my CPP of groundnut, Bengal gram, and this one, wheat and ragi. I don't encourage people to mix so many things to the nutritious powder that will confuse the child. So just 4 items, which is commonly available, easily digestible. That is very important. Whenever you give a food to the child, it should be less bulky, less voluminous, tasty, palatable.
I think whether it's a SAT mix, Madam asking is available in Tamil Nadu. Madam is asking.
What, sir?
No.
Yeah. ICH mix is there. ICH mix.
Sat mix.
Sat mix.
You can tell about Sini about ICH mix.
Yeah, that's what I told, the CPP kanji. That is, you take 400 gram of ragi, 350 gram of wheat, and 150 gram of Bengal gram, and 100 gram of groundnut, which is our previous nutrition specialists like Jnana Segar, Chandrasekharan sir, so many stalwarts they have produced in ICH, which gives one of the highest giving protein and calorie maybe in the country. 100 ml will give 12 grams of protein and 360 calories. That's why I said we are using this CPP kanji for leukemia children, in PICUs, in empyema, in bronchiectasis. All the children who needs extra protein and calories, we are using this kind of.
Dr. Sheila Pereda in Velo used to use this long back, and she was a UNICEF consultant. For sugar, she used this mix, ragi, milk, and oil. But whenever she used to say that unless you put ragi, you boil the milk with ragi, the oil won't mix. You have to, it will just come to the top. So if you have oil to mix properly, you need to have cook it with ragi before you put the oil into the.
Exactly, sir. Exactly. Especially when it is really hot, we should do that. Otherwise, you can see the fat, the oil will be near the top, and child may not like it and take it also.
Yeah, that's true. So she's
mentioning Jason only. Sheila Pereira. She has written as very good on Kwashiorkor.
Yeah, she was a UNICEF consultant for Kwashiorkor. Yeah. So we used to do a lot of Koshi work during that time.
A wonderful personality.
Yeah.
Sir, now last week, sir, I was seeing a Kwashiorkor coming even by 5 months.
Yeah, we saw 5 or 6 last year.
Yeah.
The between milk, breast milk, and weaning foods is wrong. They give wrong weaning foods. They stop breast milk and they get into Kwashiorkor. So many of them.
Recently, one of my very smart mother has started a YouTube channel where she started, giving an advertisement for her own recipe, which I think we should come under the purview of all the specialists, whether she is preparing the right recipe or what. I think I told her not to just give for advertisement your own recipe. It should be within the limit of the balance and it should be certified. So I just put a full stop to her promotion of YouTube channel, wherein she is trying to bring so many recipes with reference to the complementary feeding food.
So the idea, the idea is not to confuse children with so many things. And we should also take it that being many people are coming from below poverty status, the resources which are available locally should be used. That's why I always says the locally available resources for us is Bengal gram, groundnut, ragi, and wheat, not even rice. So these are the things which is easily available in each and every nook and corner of the village. That's why when we teach these people, they can do this instead of confusing children. And of course, these children, this is the one which is going to help you in the beginning. Slowly, we should go for an adult type of diet in these children so that they can easily get accommodated to the adult type of diet.
Sorry to intervene that Srinivasan sir for a nice comment and the Srinivasan sir for an excellent presentation. We are running short of time, so we can have your clarification in the chat box because we are running short of time. And sorry for the stopping this procedure. We will wind up the section and thank you all for active interactions and active learning by Dr. Srinivasan regarding the SAM and DAM. Thank you all. I hand over the mic to the organization team for next proceeding. Thank you, sir. Thank you.
Thank you, everybody. I have a very great guest now. I am very happy that Dr. Bakul Parekh has joined. He is actually the person who introduced these webinars into IAP. I request Dr. Bakul Parekh, last year's president of Indian Academy of Pediatrics, to felicitate before going to the next program. Welcome, Dr. Bakul.
Thank you very much. I'm very happy to be here with my friends, and I'm listening to a very nice deliberation on nutrition, and I'm sure this is going to be very useful. So please keep it up and continue with these good academic activities as usual, which Kerala is known for. Thank you very much.
Thank you. So we are moving on to our next topic, that is speeding the preterm. We have excellent faculty, Dr. Upendra Kinjwadekar, and the chairperson is Dr. Jason C. Unni. Dr. Jason is editor-in-chief of IAP Drug Formulary and senior associate consultant at Astra Medicity Kochi. He has been the national convener of IAP Scholastic Performance Program, past secretary and president of IAP and MN of Kerala. Sir, welcome back to Palakkad. Over to you, sir, to introduce the speaker and also to chair the session.
Thank you so much for the opportunity. It is a lovely session. I think all the PGs are going to enjoy this today's sessions. And the first session was beautiful. Excellent topic. So, this is a hot topic, symposium session. I think the Pediatric Academic Society's 2021, there was a virtual meeting addressing these persistent controversies and questions in preterm nutrition, infant nutrition. And after 6 years of interdisciplinary expert discussion and critical evidence review, the 2014 vision to develop evidence-informed guidance for nutritional care of preterm has come to a fruition. So it's a process which has been going on for a long time. There's a lot of controversies, and we have none better than Dr. Upendra Kinjwadekar to talk on this topic. And to introduce him, I think everyone knows him so well. There's no real need to introduce him. He's a pediatrician in Belapur, Navi Mumbai, and has an experience of 31 to 32 years of clinical practice. He's practiced in Apollo hospitals in Belapur, Navi Mumbai. He's completed MBBS from LT Medical College, Sion, and in 1987, and his MD Pediatrics from the same hospital, from same medical college in 1990. He's a member of the MMC, member of the Indian Academy of Pediatrics, President Maharashtra IAP 2013, member of Association of Medical Consultants, and member of the Indian Medical Association. And he was IAP Honorary Treasurer, and he's contesting for President-elect IAP President-elect this year. He's a pleasant and always smiling, amicable personality, good orator, uncanny knack of presenting and moderating panel discussions of case scenarios, and everyone has seen him in the national conferences for his oration and his presentations. He's has 17 publications in textbooks and journals. He's 10 author and co-author in IAP modules and his special interests are infectious disease, nutrition, vaccinology, pulmonology, general pediatrics. And I invite Dr. Upendra to start his session on preterm feeding.
Well, good morning, everybody. Thank you very much, Dr. Jason dear, for introduction, for very kind introduction. And at the outset, let me thank Dr. Shri Prasad, Dr. Anand, Dr. Adira, Dr. Jayaraman sir, Dr. Johnny Sebastian, and of course the stalwarts of IAP Kerala, Dr. T. Sukumaran sir, Dr. M.K. Sinayar, my dear friend, Dr. Somasekar, Dr. Anand Kesavan, and so many of them from IAP Kerala who are here. And thank you very much for a kind introduction. So let me start sharing my screen. Audible and visible?
Yes.
Yeah. Okay. So the topic given today is feed preterm, very important topic. And as all of us know, why is it so important to discuss feeding the preterm? Because everywhere, not only Kerala, entire country, we have so many NICUs. You could be just DCH, you could be MD, you could be DNB, you could be DM in neonatology, but the rate of newborn has increased tremendously everywhere. And everybody puts great efforts, the ventilation strategies, the CPAPs, everything has improved in the immediate survival. But there are about LBWs up to the tune of 15 to 20% all over the world, about 22 million births which are low birth weight. And in India, though the incidence down a bit, it is 28% right now. But what happens after discharge? The morbidity, the mortality, the developmental delay, long-term neurological sequelae, are we taking care of that? And all of us know that nutrition is the most important key factor. Of course, the thermoregulation, of course, the love and affection, of course, the immunization, everything matters, but nutrition remains the key factor. So let's in a couple of minutes discuss what are the key factors that one should look for in preterm feeding. So the general guidelines, everyone is aware that after 34 weeks, your sucking, swallowing coordination is perfect. So we straight away put all these babies, do not try for spoon feeding, but for breastfeeding. We do monitor their feeding ability, the tolerance, the sugars, but breastfeeding is the order of the day after 4 weeks. When the baby is 32 to 34 weeks, we try to start feeds by OGT. If not, baby is not stable, has clinical complications, then only, or the baby is sick or not tolerating feeds or has hypoglycemia, we go for alternative methods. When it's a 28 to 31 weeker baby, we try to start on IV fluids and minimal enteral feeds, gradually go up to 20 to 30 cc per kg, but try to transition to oral feeding at the earliest, maybe by 32 to 34 weeks. And less than 28 weeks, we do not take any chance, and still we put this child on parental feeding. But what is very important, whatever may be the gestational age, whatever, all of us are propagators of breastfeeding, exclusive breastfeeding as much as possible, but not at the cost of hypoglycemia. So all need to remember that hypoglycemic brain damage is extremely avoidable. So let's do anything but monitor blood glucose. Can we mute others, please? May I request the host?
Dr. Anand, if you mute all of this, there is a lot of sound is coming. Anand, Tony, please hold.
Will do, sir, will do.
Vedra, please unmute.
Yeah. So the feeding practices would be from the mother's own breast milk. That would be the ideal choice. From that, we move on to donated fresh preterm milk, then donated fresh term milk. But we know that the preterm mothers do not produce so much of milk that they can donate. But then the choice comes to mature milk and then pasteurized donated breast milk. So whatever said and done, either mother's own or a donated mother's milk is what is most important. If not, the last two choices are preterm formula, ordinary formula, and they are. So let's hope that baby gets and deserves what she wants to get, that is the mother's milk. I don't know why the slides are not moving. Hello, am I audible?
Yes, sir, you are audible. You are audible.
But then the slides are not moving.
You can stop share and then come back again.
Or click on the slide itself.
Okay, great, Bakul bhai. Thank you. So what are the frequently asked questions as far as preterm feeding? Early trophic feeding. Now the order of the day, all of us initially used to keep the babies NBM, but it is within 24 hours is recommended, except for extreme preterm or extreme low birth weight baby who is less than 1 kg. So we should remember that early trophic feeding is extremely important. How to advance? In our center, we advance by 15 to 20 cc per kg per day, but one can go up to 30 cc per kg per day if the baby is tolerating, stable, and does not have any other complications or any signs of feed intolerance. Very important point again, that when I was fresh postgraduate or initial maybe 10 years of practice, we always used to do pre-feed gastric residual. If it's more than initially 25%, somebody said 50%, then continuously monitoring abdominal girth. But now it is all given up. The evidence is that you do not handle, do not touch the baby unnecessarily. So clinical monitoring is what is important, and one need not every time do a pre-feeding gastric residual or abdominal girth measurement. How should I give it? Is it continuous or is it intermittent? So continuous feeding is never recommended as a routine strategy for feeding preterm LBWs receiving intragastric tube feeding. So it is always intermittent. Then how frequently should I give it? So all the babies who are low birth weight or babies who are having weight more than 1,250 grams, we must try the cup, palati or katori spoon feed should be fed every 3 hours. So it becomes less intervention. The tolerance of the feed is much better as compared to 2 hourly. So all these preterm LBW babies, especially less than 1.2 kgs, must be given 3 hourly feeds. So it becomes 8 feeds in a day rather than 12 feeds. Erythromycin or any prokinetic drugs, not at all. There is no recommendation to use them for feed intolerance in preterm babies. Routinely, we used to have when patients have been, babies were given ranitidine or erythromycin. No, it is not required at all. So ensuring smooth transition. Now we are preparing, our baby is stable and we want to discharge and do not want these babies to come back with problems. So preterms are usually, all of us know that the recommendation is different, but because of economic constraints of stays in NICU, we do discharge all these babies much before than they actually are recommended in the books. But smaller and weaker babies can get fatigued very early, so they need to be, long sucking is not possible. So we help them with cup, palati or katori spoon. If it is not possible, we go for nasogastric or OGT, and intragastric is preferred over transpyloric route in all these preterm infants. So we must start gradual transition. We are preparing these babies to direct breastfeeding by few intermittent feeds, by starting from 33 to 34 weeks, and then follow it up with spoon feeds. So direct breastfeeds are slowly increased in number and duration as per baby's ability. So there cannot be a single standard uniform formula. It all depends on how the baby takes up the feeds, responds to that, and then we can go and further increase the feeds. So, but on reaching 2 kg, most of our babies, that's so gratifying to know that they will completely breastfeeding. So what as a neonatologist or a pediatrician should I ensure before I send these preterm babies home is they should have at least sustained weight gain in NICU for 3 days. There has to be a physiological stability. There should be euthermic. We have to spend time of mother and kangaroo father care, very important. Competent oral feeding has to be ensured. Parental involvement and confidence, I think amongst all these, this is the most important. Even the grandmothers, the husband, wherever, now next 3 months, usually they go to mom's house. That is a practice in Maharashtra. I'm sure that must be the same in South. So you have to involve the mother-in-law or the mother or the sister that what kind of care they need to take at home, and regular outpatient follow-up at least weekly, because they come straight away. Otherwise 6 weeks vaccination, that's too late. So we need to monitor these babies even after discharge very frequently. Now comes the very important, initially it was a controversial, but now everywhere, starting from NNF to IAP to A, talks of fortification. There are 2 types, single and multi-component. So what is recommended is multi-nutrient fortification for those less than 1.8 and receiving at least, so baby has to go up to 50 to 80 cc per kg per day of enteral feeds, that is EBM or direct feed. And if not, then we have to give these babies also fortification. So there are, we have know that ours is a resource limited setting only for those who are failing to gain weight despite adequate breastfeeding. So again, there is not a generalized recommendations. So you can have, if the patient is not affording, mind you, all these fortifiers are costly to the tune of 25 to 30 rupees per sachet. And if you are telling them about 4 sachet, 1 gram sachet 4 times or something like that, it becomes really an expensive affair for most of our babies. So point is, if your baby is able to maintain weight with good EBM and direct breastfeeding, no need. If not, you can give it. And how long should I start and continue it? So some policies are up to discharge, some say up to term, and some say up to 50 weeks. So all these are evidence backed. But in our center, what we usually do is discharge or maybe at the most till term, never given up to 52 weeks. So what is the need? What is the scientific basis? Is one should understand, if I give only EBM to these babies, energy may be on the lower side, but proteins, and for neurodevelopmental outcome, it is a proteins. It is not 1 gram per kg or 0.75. It is that the babies are recommended. Carbohydrates, fats are not problematic, but look at the calcium, phosphorus, vitamin A, D, all these micronutrients, the EBM, even if the baby is receiving 180 cc per kg, everything will be at a shortfall. So that is a scientific basis why we need to give fortification to these babies. if I give fortification at 180 cc per kg per day with a bovine human milk fortifier, most of the things are taken care of. One has to remember that though breast milk also, it is not at all, it is very extremely variable and goes down after about 3 weeks. So that is the reason, and we do not want these babies to suffer from protein deficiency, because very important. But whatever said and done, even if there are human milk fortifiers, but pretty expensive, I must use the word extremely expensive, so not really recommended. But even if you use them, or even if you use a formula, still the baby phosphorus, vitamin D, iron, even with this kind of setting. So that's why one has to remember that just by giving formula or a mother human milk derived fortifier doesn't solve your problems, and one has to supplement these babies. So now again, you will ask me, Dr. Upendra, can we use, because let's see the cost part, 25 to 30 rupees for a fortifier, bovine fortifier, whereas a preterm formula, if I use it in the same proportion, it will be 70 paise to 1 gram. And fortunately, there was a study which is just published 3 months ago, that too from our country, and which says that fortification of what is the comparative study between two, and look at the key points, that fortification of express breast milk by preterm formula was non-inferior in terms of weight gain. If with fortification, it 16.3 grams per kg per day, it is 15.7 with a formula. So not a great difference, so non-inferior. So that is very important. In a resource limited settings, one may go for that if the baby is not gaining. Again, remember that bottom line is very, very important. And now let's come to very, very important part, that is growth chart. Not only nutrition, one has to monitor. And if all the pediatricians start getting into habit of using a preterm for a growth chart, I'm sure that even the term babies, which they deserve to be on the growth chart, would be plotting it on. So which growth chart should I use? It should have both components, less than 37 weeks as well as postnatal. Initial postnatal weight loss has to be, because all babies lose weight. They need to monitor weight, length, and head circumference, and of course a catch-up growth. So what are the choices that I have? Two choices you have. Fenton chart 2013, which is a gender specific, again from the WHO derived formula. So what they have done is all this multicentric data has been pulled, and then after 40 weeks, the same chart is to be used. So it's a WHO chart for gender specific. So in my center, I use completely these Fenton charts, and I am comfortable using it. So this is one option you have. Any other option? Of course, Intergrowth 21. What is the difference? Millions of babies were studied in this, so large cohort, and then these babies also right from first USD, antenatal USD, they were followed. So it's a very great follow-up which was done, and the studies, the figures derived in this study are much better, maybe I could say, the Intergrowth 21. So you have this second choice which you can also use. So if you're comfortable with that. What is the difference, you may ask, Dr. Upendra, if I am Fenton, should I shift over to Intergrowth? Now look at, again, there is a wonderful article just recently published on comparison of Fenton versus Intergrowth 21 in our babies. So they have studied both parts. So this is from a Hyderabad group led by Dr. Srinivas Murthy. What they have shown is the babies who have IUG, suppose there are 2 points that see, that SGA babies with Fenton chart could be to the tune of 18%, which were shown to be 16% in Intergrowth. So there was 2% higher prevalence if you use Fenton. And EUGR, the extrauterine growth restriction, if it was 45% when Fenton showed, then it was much, if it was 52% in the Fenton chart, it was 45%. So the point is, you may have slightly increased prevalence studies if you are comparing with these two on EUGR as well as IUGR. So that's a maybe a little bit of difference, but you have been using it properly. I'm sure that it will be different. Then let's come to supplementation. The calcium, phosphorus is very important. Those babies who are on their own mother's milk or donor human milk should be given. Calcium is extremely important for these preterm babies. 120 to 140 milligram per kg per day, phosphorus 60 to 90 mkd, and it should be in the first months. In my center, I use it for 3 months, but if you ask me science, some people have quoted up to 6 months also. And especially the VLBW babies, metabolic bone disease, which we want to avoid, and it's a low cost intervention. Come on, compared to anything else, let's not go into details at why calcium supplement is. So up to 3 months is perfectly all right. And the sentence won't be complete without vitamin D, no controversies at all. Although the recommendations have differed from different bodies, from 400, 800 to 1000 I use in ESPGHAN recommends, But the point is, term or preterm baby, every baby at discharge, you must ensure that the baby gets vitamin D supplementation. So get familiar. This is a practical tip for all of us, that some of the brands, as you know, I did not take the brand names, that the elemental calcium is 82 milligrams. So maybe osteocalcium 150 milligram in Calcimax, and maybe Shell Cal has 250 milligram. That's a huge difference. So you cannot have 2.5 ml BD, 5 ml BD. Please, 120 milligram per kg per day. You want to see calcium, phosphorus. Look at the Shell Cal. It does not have phosphorus. Look at the vitamin D. It should not get added up, because you want to use it about maybe 400 to 600. So this additional prescription that you are creating will have this, will be always there. Vitamin D will always come. There is no brand which is without vitamin D. So please don't say that it's for blanket 5 ml BD or 2.5. Get familiar with the brands that you are prescribing. Now, of course, the iron is extremely important. Simple formula: smaller the baby, earlier the delivery, longer is the duration, earlier the start. So babies who are less than 1 kg, you have to give 4 milligram per kg. We can start once the babies are stabilized 4 to 6 weeks, and then babies need to be continued to be on iron supplementation till about maybe 12 to 15 months of age. So this is important. If the baby is even more than 1.8 kg, the dose of iron becomes much less to 2 mkd. Again, same point about elemental iron. Know your brands that you are using. All of us know some of them, and it's the elemental iron that counts, right? So some of them have 25 milligram of elemental iron. Some of them have 20, some have 10. Some of with B12, folic acid, lysine we do not want. Why do you want to use lysine? So these are the points one needs to. So get familiar with 1 or 2 brands, and then you can use them. But the point is, calculate the elemental iron and then give your prescription. Multi-strain probiotics. Now, evidence says that may be initiated in LBW babies on day 1 of life, continue to 36 to 37. But which babies? Where you have a very high baseline incidence of necrotizing enterocolitis. What do I mean by very high? It should be more than 10%. But fortunately, friends, let me tell you the Mumbai experience, even my personal experience over the last 5 years or so, and most of the centers in Mumbai, they have said those who are using EBM or a donated mother's milk, the incidence of NEC has come to 0, especially the grade 2, grade 3. So let's not get into probiotic. And I'm sure everywhere the response and the readings must be same, that we have all reduced incidence of NEC. So let's not get into unnecessarily probiotic supplementation. And if you are having a very high rate, then let's again reassess. Maybe we are using a preterm formula instead of a EBM. Vitamin A, we used to do that. We used to recommend it. In fact, in our module also, we had talked about it, Nick. But now the latest recommendation, routine oral or iron supplementation of vitamin A is not at all required. What about zinc? Same thing. Routine zinc supplementation of LBW who are fed EBM or donors human milk is not required, because though some may say, what is the disadvantage? Se kuch harm hota hai kya? No, but then there is no evidence of benefit. So let's not unnecessarily add up to all this. Again, DHA, yes, agreed. Mother's diet should have good DHA, retina, brain infection, neurological improvement, perfect. But should I supplement it? No, not at all. So none of these preterm babies do not fall prey to advertisements. They do not require any supplemented DHA or long chain PUFAs. When to start complementary feeds, it remains same. So it will be corrected age. Now the baby is 28 weeks, becomes as always advantage of 12 weeks. So look at the corrected age. Look at the other points that baby should be around 5 kg, should have some neck support, and tongue thrust reflex should have diminished. So complementary feeding recommendation is not different from a term and preterm baby, and it will remain the same. Long-term metabolic one. Now this is very important. All of us want to see that baby who was on the lower percentile line has to come to that 50th centile. No. Accelerated growth in infancy in a growth restricted LBW is associated with enhanced risk of obesity, diabetes, hypertension, cardiovascular disease. So this is the fetal origin of adult disease. So all of us know developmental origin. So this is very important. Let the baby grow as per her trajectory. Let it come gradually to normalcy. And let's see to it that unnecessarily, in fact, if the baby is crossing and becoming normal by 2, 3, 4 months, something is wrong, and we need to monitor these babies for obesity and further complication. So friends, our goal for this preterm feeding at the end of the day is healthy catch-up. So this is very important. I do not want these babies to have neurodevelopmental handicap. At the same time, I do not want nutritional deficiencies, but at the same time, I do not want the iatrogenic complication of obesity, or metabolic syndrome, or hypertension when the child is maybe about 12, 13 or 18 years of age. So all this is difficult to prove and do at that time. So everybody feels and likes a nice chubby baby, but let's go slow on this as far as healthy catchum is concerned. And finally, let's remember before concluding, that's the last slide, that all of us must ensure that breast milk, let's remember, in terms of quantity and duration, has consistent benefits. You take mortality, morbidity, cognitive function, prevention of obesity, reduction of metabolic syndrome to LBW. So let's completely put in our efforts for mother's lactation, giving her confidence, right antenatal. I know sometimes it's suddenly she goes into labor at 28 weeks and delivers. We have not prepared her. So I agree to that, but still there is a chance, and every baby deserves to get mother's milk. So let's put in all our efforts so mother's sustained lactation. Every effort should be made to provide maximum breast milk to LBW from birth through the first 2 years of life. And then if we can do that, I'm sure that those babies who are given taken care of, good kangaroo mother care, good nutrition, good love and care at home with proper vaccination, by the time they're up to 2 years of age, they would be coming back to a normal infants and can compare with the other children. Thank you very much for your patient hearing.
Thank you, sir, for that excellent presentation. It was a power-packed presentation, so to say. Due to the lack of time, Jason, sir, can we move on to the next? Would you like to add on something? Otherwise, we can move on to the next session. So you're muted. Jason, sir, you're muted.
Jason, you're muted.
Jason, sir, you're muted.
Dr. Jason, Jason, you're muted.
Hello?
Hello, you have to unmute me. Yeah, you unmuted me now.
You're already unmuted.
Yes, sir.
Excellent talk, Dr. Upendra. Now this, there are chat boxes yet, but I wanted to ask, do you do routine, gastric residuals? Do you check?
Not really. So that's why we have stopped. We were doing it. And if the aspirate was more than initially, we did it at 25%, then it came to 50%. But now we have stopped it. So unnecessarily, there is no intervention. Touching the baby, unnecessarily doing that, it's really hampered. So it's not recommended.
Abdominal girth, do you do routine?
No routine abdominal girth measurement. Given up.
And do you rely on apnea, desaturation of bradycardia, behavioral signs, marker of GER?
Of course, one has to consider those subtle signs also. Very, very important.
So GER, do you use any medication, or it's just the positioning that is important?
Exactly. So one has to remember that it's usually physiological, and most of the times with positioning and proper feeding technique, burping the baby and then keeping in a proper position, usually they overcome. So you do not need pharmacological intervention in these babies.
Very good. These are certain points that we wanted to emphasize. And which are the conditions which you don't advise human? You don't rely on human milk. Any?
In a newborn, no. Actually, we do not come. I have not come across any condition where I had to stop or do not say that the baby deserves mother's milk. So every baby usually gets mother's milk, either EBM or a donated. So we have good banks also, so we can. So usually, and it's a mixed population. So sometimes a term baby's milk is easily available. If not preterm, then the term baby's milk.
And is there any term called individualized fortification and adjustable fortification? Is that?
Yeah, as I said, that individualized and adjustable, that means you're catering to the baby. So the point is single monocomponent fortification. We used to do it earlier when simil MCT oil or something like that. In fact, the evidence is against that. It has been proved there is whatever publications are against the single monocomponent fortification. Or if at all, one has to do multi. And only if the baby is not able to sustain. So now, if a baby is 1 kg, I consider 10 grams per day should be the baby's weight gain. If it is not happening to that, then maybe for a sustained period of time, I may have to use fortification. If not, if the baby is on EBM properly growing well, then there is no need.
There's a question, what is the ideal catch-up growth in a preterm?
So usually catch-up growth terminology is used till 2 years of age. So we give that leverage to the babies. As I said, if it's a 28-weeker, we give till 2 years, 12 weeks of advantage to that baby. Once the baby is 2 years, then we do not call them catch-up. So we use the chronological age, not the intrauterine age. So that is very important. So that is how one has to monitor these babies for catch-up growth till 2 years of age. Some say 4 years, but then 2 years is good enough.
Sir, as we are running out of time, shall we wind up the session?
Yeah. Thank you so much,
Thank
Dr.
you.
Upendra. Lovely session.
Thank you, everybody.
Thank you so much.
So we'll be moving on to the next session, that is feeding neurodevelopmentally challenged children. The faculty for today is Dr. R. Somashekar and the chairperson is Dr. Ananthakeshavan sir. Dr. G. M. Ananthakeshavan sir, he is the additional professor of pediatrics at GMC Trishur. He was IAP National Vice President of 2020, past National President of IAP Neurology Chapter and whatnot. Welcome you, sir, to chair the session and also to introduce the session.
Very good morning. At the outset, I would like to thank the office base of the nutrition chapter and IAP Palakkad for giving this opportunity. I also would like to congratulate IAP nutrition chapter for organizing a wonderful CME. The neurological problem and feeding of them is a very important issue. Many mothers are more concerned with the feeding problem rather than the neurological problem. We can see so many mothers with the complaining of not taking properly. So the problem starts from the sensory system of the child. Smelling of the food is not possible. Taste, vision of the food, and the proper utilization of motor system, autonomic system, everything is affected. As already mentioned, you can see so many types of neurological problems, and the GER is another important problem. So that we have to give them more inadequate food. Both quality and quantity is compromised. In certain situation, serious situation, even we have to go for the surgical situation also, surgical intervention also. So to talk this, we have a MD speaker, my friend, and also National Vice President of IAP Social, Dr. Somashekar. And he is Professor of Pediatrics, Sri Balaji Medical College, and also ex-Dean, Kanyakumari Government Medical College, and also Honorary Secretary of Nutrition Chapter, and also he was a FIAP awardee, and he had many publications. I think after he took over the charge of the nutrition chapter, become one of the most active chapter in IAP. So with this, I welcome Dr. Somashekar.
Thank you, dear Ananthakeshavan sir, for your very warm introduction. I thank the IAP Kerala and the IAP Palakkad, especially the team PEDNUTRICON, Sri Prasad and Adira and everyone, my beloved friends. And dear Ananthakeshavan sir, it is indeed a great honor and privilege for me. And at this juncture, I thank our mother of pediatric nutrition, Professor Dr. Elizabeth Madam, has given me this topic to talk about on this thing. So I feel that this is one of the most unexplored topic. That is why Madam wanted me to talk about this feeding in a neurodevelopmentally challenged children. When we were asked in the exam, about how are you going to feed your baby in a challenge, especially cerebral palsy children is given to us, we usually say that the children, they have a poor oropharyngeal incoordination, so they tend to limit to only the liquid at the end. So how much they are compromised in the why I'm getting frequently muted. The host is trying to meet me. Oh, I'm sorry. Able to hear me, sir? Ananthakeshavan sir, can I go ahead?
Sir, I have just muted all the participants, sir. You can continue.
Yeah,
I can continue. Oh, okay, yeah. So I'm continuing. Okay. This is the most unexplored topic which I have said. So then another 30 to 35 minutes. I beg a pardon if I exceed 5 minutes more. Kindly bear with me because I have a video also to be shown to the audience here. So my way forward in my presentation would be to start with the Hippocrates oath. This is about 400 BC year ago. I think the let food be thy medicine and medicine be thy food. Whether are we following this? Is there any fallacy in this Hippocrates oath? Let's wait and see and watch. At the end, I will come out with a solution. So the overview of my presentation in the next 30 minutes, as I said earlier, would be what are the challenges these mentally challenged children they face in the feeding problems, and how do they present to us, and what are the problems they do present to us, and looking at the feeding difficulties and what are the factors which contributes to the feeding difficulties, and how do they present, what are the nature of feeding problem, and in what by what means they present to us, what are the features they have while they present to us, and do you have any evaluation mechanism to evaluate these poor children, or is there any instruments available, and what are the long-term complications, and how are you going to prevent? That is the, I think, the key message for today. I think the theme for this year is feeding smart right from the start. Will pertaining to this challenge children, I think it is apt. We should concentrate, feed them right from the start. We must feed smart right from the start. So with this note, let me start my introduction. That what are these neurodevelopmentally challenged children are going to face. So they often encounter so they often encounter a feeding disorder of a swallowing problem. Then in many instances, they place them at risk of aspiration with oral feeding and potential pulmonary consequences. This is what I've been taught here. They also commonly have reduced nutrition. I think in a subset, we should think about it. This is really very pathetic and heartening. So the hydration status, what about the hydration status? And the most important thing, the parents, they do experience a prolonged stress meal plan. So the specific nature of the problem and the severity of the swallowing problem may differ at least to some degree in relation to the sensory motor impairment. Is it gross or fine motor limitations? And with reference to cognitive and communication deficit. All these are going to be explored in the next couple of minutes. So another problem, the children with this problem do have a motor impairment. For example, spastic quadriplegia. They are likely to experience greater swallowing difficulties than the diplegia. But the oropharyngeal dysphagia is prevalent even in children with mild cerebral palsy. This is, I think, mind-blowing that we need to always concentrate. Even the milder form also do exhibit poor motor oropharyngeal incoordination too. The next thing is about the concerns and the multifactorial issues related to the food intake, the volume, how much they intake. Irrespective of the diversity of the food, let us not come to that later. But the volume they consume is also very less, and they do have a nutritional deficiency. And because of the inadequate hydration, a limitation in the range of textures with the slow and advanced oral skills. So the oral skill also, because of these texture variation, tend to probably limit their oral skill development. So what are the presentation? How do they present to us? They either present with inadequate growth, or if they present to us with prolonged feeding time, they have experience a delayed progression of the oral feeding, as I told you just now, and they do have a recurrent respiratory infection. They are more prone for, as you all know, they have a siluria, the drooling of saliva, which is really very pathetic, as you see here in this poor mother who brings their children on their lap, which the child just drooling and it is wetching all the spot, everything. So there is a delayed laryngeal elevation reflex, and the penetration, the aspiration of food is likely to occur. And the chewing with open mouth, they tend to chew with an open mouth. What are the maneuver, and how do you adjust to the maneuver? What you teach them? How do they take the food inside? And there is a voice change. The voice also tend to change because of the drooling. As you see, they do have a wet voice. So the persistent oral reflex and pathological reflex is another problem which they hinder the feeding. So the features are the poor head trunk alignment. They are not in the midline. So either they are too flexed or extended. What will happen when they tend to flex and extend? They're going for a stiffening, all these things, and the mouth is kept open. The jaw in the extension pattern can be associated with hypertonia or hypotonus. The mouth kept firmly closed. It is associated with hypotonia and the bite reflex, which is where there is a irregular swallowing. Take a quick breath, and there is an uncoordinated and non-graded limitation of movements of the jaw, which leads to lack of rotation, little or no chewing at all. And the passive lip, which lack of lip closure, to especially the upper lip, which is round and retracted, and the lip is often pulled, to the up and keep it very tight for the swallowing. So the tongue which tend to fall forward because of the thrust, and there is a lack of grinding, and it is due to the lack of stability of the lower jaw, not providing base of the support for the selective movements of the tongue in all the directions, and the excessive production of the saliva and poor saliva control. So tend to lead to the drooling, and which is unintentional spilling of saliva from the mouth into the lips, chin, neck, and clothing. As you see here, as I told, that the children looks very fat while being placed on the mother's lap. So there is an ineffective delay in the swallowing. The mouth is full of food, which is trying to hold it and not even able to, chew it and tend to bring it back. There is the food likely to spillage and the bites and the food remaining into the mouth, especially at the back. And there is a chance for aspiration, which happens at any phase before or during and after the swallowing. The vocalization sounds also because leads to wet voice and the cough, choking, gaggling, and crying and blinking, abnormal facial expressions, which leads one to see the aversive reactions towards the food. They increase the tone and leads to the voluntary jerky movements and so on and so forth. So the factors which continues, which we analyze one by one, it is because the oromotor dysfunction. So the clinical feature of these oromotor dysfunctions are ineffective sucking and swallowing. There is a drooling. There is an impaired hydration dealing as a result of drooling. There is a perioral or hypersensitiveness, and there is a poor tongue function. There is a increased tongue thrust and difficulty in self-feeding and increased coughing and choking and so on. So as a result of sensory motor dysfunction, the sensory part, which is very, very important, the texture is not felt. That is why the children likely to be living on only the liquid food. They are unable to hold the food under the tongue to avoid swallowing. Certain texture are try to vomit, and then you try to probably thicken the child pathetically. This may that the child tend to vomit out. And another problem is the motor defects because of the guilt of defect, unable to hold or manipulate food on the tongue. The food tends to fall out of the mouth, and the vomiting, which is non-texture as texture, non-texture specific. Vomiting is as not resulted to the texture, which is non-texture specific. And coming to the speech and communication disorder, in normal to slight imprecise speech, we have a better feeding difficulty. So if it is slight, then we'll have a better feeding difficulty. But if there is a severe speech impairment, which leads to decreased feeding ability, cannot ask for food, and therefore what happens? The baby is deprived of the nutrient food, dependent on feeding on a tube or a. This is what happens. Ultimately, we do see the devastated the babies with the burnt out case which comes we receive in the ward are often put on a tube feeds. This is what is the end of the story. Then the postural problems what we encounter because of the poor posture due to weak head, trunk control, and inability to maintain the body posture. The neck is hypertensed back, and the tongue which will have a retraction. There is a depressed mandible swallowing disorder. And early the age child will have weak suck and delayed and absent tongue lateralization and persistent tongue thrust, poor lip closure, and there is chances of tongue instability, which I told. The others are occurrence of the seizures and cognitive intellectual impairments. So this is what is more important. The next chapter of my talk would be about what are the nature of feeding problem for the poor children with this the mentally challenged children when they do come across. They are either inability to self-feed themselves, they take a longer duration of feed, might take even up to 7 hours a day. This meal time is most horrifying that because of the repeated spillage of food, coughing and choking, and there is they tend to regurgitate. And as a result of the drooling, what happens? There is a decreased salivary flow rate and the pH is lowered. there is a buffering capacity is decreased, which leads to decreased liquid intake due to decreased oromotor performance, which leads to inadequate hydration status. This is very, very important to note. So what are the other nature of feeding difficulties? These poor children, they come across, they have a swallowing problems. The signs of problems are the aspiration, choking and coughing, as I told you earlier. The factors which causes these are the bite reflex, the slowness of the oral intake, the poor trunk control, inability to feed independently. Maybe some children on anticonvulsant medication also, because of that, they are not able to, exhibit this tone, and coughing with meal time and choking and so on. So because of the tongue thrust, the drooling and severity of the CP, there is a poor head control, seizures, issues, and there is a speech disorders which advancing age. So the chewing problems from liquids to semi-solids, and another nature of the problem which we encounter, the GERD and vomiting. This will lead to the failure to thrive, anemia, and recurrent chest infections. And the others are the tongue movement, which are inadequate, as I told, that because leads to sucking problems, wide open. The mouth is often kept wide open because the first bite reflex, jaw instability is ensuing. So how do you evaluate these children, mentally challenged children with the feeding problems? What are the questions the parents should ask, and you as a caretaker should ask? So the key questions to be asked are: how long does the child take your feed? How long it takes to feed your child? What is the time you take to feed your child? So are meal times stressful are the meal times stressful? So what are the red flags you need to assess asking these questions? Are there any signs of respiratory problem? How long does it for the child to take a feed? If it is more than 30 minutes or on a regular basis, then there is a red flag. If yes, and meal time be stressful, the next question which you ask to the parent, if the answer is yes, if one or other or the both, then yes, definitely these children need to be put on a red flag. So are there any signs of respiratory problems? The red flags are yes, definitely. The lack of weight gain over 2 to 3 months in a young child, or just even a weight loss, so is a red flag. So if there is a respiratory problem, you should ask for, there is an increased congestion at the meal time, the gurgly voice, and respiratory, following a respiratory aspiration leading on to respiratory aspiration and so on. If there is any respiratory illness, admission also, then definitely the children need to be evaluated. So observe these children. I think the time and goal, the inspection, palpation, percussion, auscultation, the observation, which I think need to be done at your expertise. These children need to be observed. This is very, very important in your clinical acumen. So what are you going to observe on these children? So is there any instrument to evaluate the swallowing? Yes. How do you go about that? Is there any criteria? Yes. If there is a risk of aspiration, if there is a previous history of aspiration pneumonia, as I told you earlier, which is a red flag, if there is a pharyngeal or laryngeal problems, or if there is a gurgly voice, these are the children needs to be evaluated with instruments. What are the instruments available? So there is a video fluoroscope swallow study, which allows the visualization of all phases of swallowing. And there is a flexible endoscopic evaluation of swallowing, which allows the direct visualization of the structures, which does not infer any radiation hazards. So you can test by handling the secretions, do a sensory testing too. So coming to the next part of my presentation is how are you going to manage these poor children? What is that we need to have a goal? What is the goal which we need to follow? The golden rule is that the main aim of the management to stabilize the airway with adequate nutrition and hydration. Feeding or swallowing intervention should be pleasurable, and it should be non-stressful for patients as well as for the caregivers. A child must take part in family meal time. That is what we used to say always. The 1-year-old child must have a family pot feeding. And even if not fed orally, it should, even if the child has got some problem with the feeding, it's not able to be feed orally. Also, it must be placed in the vicinity that when we all feed, we must be in the midst of that we all take food. And coming to the next in the goal is that the postural management, which plays a very vital role. So how are you going to manage the posture? So you use a proper technique to normalize the abnormal tone and develop more normal pattern of the movements. So the seating arrangements to be looked into. What are that seating arrangements you are going to have? So the child must be given a more comfortable seating arrangement, as you can see here. As long as the baby is 6 months, up to 6 months, you encourage exclusive breastfeeding. And more than that, while you start your complementary feeding, you see that I'm sorry that the baby is fed on, seem to be feeding on a bottle. I think I'm sorry for that, madam. And this is a Western photograph, which I'll delete in the next. And should be made to be safe while feeding. It should be made sit upright. This is what you can see here. And you can assess, make the baby to have a very good handling techniques to maintain the head, trunk, or aligned in the upright posture. This is what you can see here from this picture. That as far as possible, the baby must beyond 6 months must be made to sit, not just lying on the bed and feeding. If the child, if suppose older the child tend to fall, you can have a safe belt, like you can have this like kind of a thing. And never this is rather always troubling that you can see, instead of the making the child to feed on a sit, and the lying posture, you can make the child comfortably seated. When you try to, again, the problem is that the child with cerebral palsy, when even the mildest tilt of the head, back may cause the whole body to have a stiffening like this and to tend to arch backwards. Those, nevertheless, you try to, bend the head to any side because tend to, going to the posturing. So you can make the arm, rested on the chair table, which is on the equal to the eyes, and then if the baby can be offered what type of a plate and food spoon, will come to that later. And the hand and the mouth response. The hand, as you all know, that what a sensory cortex is very close in the to the mouth sensory cortex. Therefore, we're stimulating one is the other is activated. So this is very, very important. Stimulation of one hand sensation, manipulation, grasp, release, hands to face before and during after feeding can help. So one should help the baby to have a grasp is released, hand is faced on, to the taken to the face, closer to the face before and after feeding, can show that movements are made visible. So the next thing is about the provide an adequate sensory oral experience. Your child with a cerebral palsy normally misses the mouthing experience. All of us know. So it is important that the sensory feedback that helps the development of the chewing pattern. So we tend to provide as much as possible. The mouth should be kept open. So the tongue movement must be enhanced. How are we going to do that? So therefore, it is good to provide a touch on the face and around the neck of the mouth, through like, kissing and the stroking, letting the child, the caregiver's finger with the supporting the child to bring his back to the finger, mouth, holding the teething joints for the child to chew on. This is, I think, really worth spending time before you start feeding this baby. This is what you can see here from this picture. So they applying a gentle firm pressure downward on the tongue can help some children achieve better lip closure and clear the spoon, avoid further tongue movements. You can place like this, so that the child is likely to have a good support and poor, good control over the overall. And you can simulate the upper lip closure by placing your finger on the upper lip. And you can also use to, give a firm pressure using your spatula or a spoon on the tongue can help some children achieve the better lip closure to clear the spoon and the food. So next thing is the position of the feeder. And this is what we often call it as a responsive feeding, the environment which makes the feeding time more joyful. It is not just feeding alone. If the feeder is in front of the child, in the midline, this will facilitate the communication with the child. So nevertheless, you tend to be seated behind or from the side. You tend to be in the front of the child while you try to feed the baby. And the timing and the feeding pattern, and the food quality is also another problem. So the child should be able to clear the food before taking a new spoon and should recover the breath before while giving the next feed at a time. I mean, to the next time. So use different food texture, temperature, and taste also matters. So use different food texture, the temperature, and the taste to improve the sensory response, which is very important to before you make sure that assess careful with the texture may be potential to cause aspiration, that which is matters. So you can see here from this picture that the mother with a caregiver who is trying to help the child to hold on to the spoon and resting on the arm here and using trying to feed by himself. You can see here the plate is also in the vicinity and high-rise table. And if probably the child could spill over with the one hand, you can have this kind of a cup using having a two handle. This is more often useful that these kind of challenged children can rest on the both elbows and holding on to both the handles and feed so comfortably and joyfully and enjoy the feed well. So next comes to the food diversity, which is also important. The 4 groups, as we also always say, green, grams, and grapes, and the food groups. That is, how are we going to give? It can be either give to chopped, easy to chew, or you can give, fine minced meat that sometimes, like finely minced, which you can easy to chew. And you can also give pure, which is also blended, which can be easily fed. So what is the choice of the right feeding equipment? Do the children, challenged children, do we have any special equipment? Yes, of course. The rolled bubble egg, as you see here from this picture, and you can see here in this picture, there's a plastic high wall plate. So the food which is kept here is not likely to, by using the spoon tending to take it, it's not falling off the plate. So drinks may need thickening, and so that it moves slowly, giving the child time to organize and to have a safe swallow. And you can have a shallow, and you can see a very shallow spoon, which is not likely to, less likely to injure the lip. And you can have the U-bend spoon, which is rather very useful, help the child remove the food from the spoon through, even though there is a lip closure. And another instrument which you can advocate and advise is the flux cup to change the shape. This is the flux cup, which are likely, used quite often. And they allow the drink to, with little or not head and neck movements tilted often. So you can have this kind of a thing which you don't allow the child to tilt the neck here and there. That will probably, as I said, will promote the reflex, the posturing. So you can have this kind of a cup which you can easily feed these poor children. So what are the dietary supplements? Yes, of course, the growth faltering can be appreciated as early as even 6 months to 9 months. So that is the window of opportunity. We don't want to give these children to give the best start. And we also should follow the safety net that the inadequate nutrition leads to a negative impact with reference to the motor development and the motor skill and the ability to catch up the infection and to fight the infection and to maintain a general well-being. So we need to also focus upon the window of opportunity, the best dietary supplements in reference to micro, which my friend Srinivasan has already told, and Upendra has very nicely dealt in the previous gesture. So these children must be promoted as far as possible, like the self-feeding, which is always we talk about. And when the child cannot be fed orally, lastly, we need to resort to nasogastric feed tubes, and lastly, the gastrostomy, or both can be used. So this is we don't want this child to go on to this stage. So we limit with the rule of 10 that we need to maintain the earlier, what all I said, I think will not go into develop these kind of feeding tube usage and so on. So the dietary problems can be due to the diet per se. So leads to inadequate weight gain, dehydration, and constipation, what the diet you use, and the poor oral hygiene, And as I told you, the gastroesophageal reflux. So long-term sequelae must be looked into and to be focused upon the 1,000 days concept, because catch them young is the need of the hour, that which can lead to the poor general health due to low calorie intake and continuous infection, the compromised chest status due to vitamin deficiency and the rickets and so on, the poor bone mineral density, and thus therefore leads to recurrent respiratory infections. So ladies and gentlemen, thank you for your patient listening. I end up with now saying, is that Hippocrates oath holds good? Maybe the food Thai medicine holds good, but the intricacy in feeding these children with this challenge, which they are undergoing, matters a lot. So thank you very much. It is time to probably change the Hippocrates oath, and allow me to play this YouTube for a minute. Thank you very much for your patient listening. To know the problems that these poor children are facing in their day-to-day life. Sorry, this is not the one.
You're not able to see the videos.
Not working. So thank you, Dr.
No, I'll stop sharing.
Yeah.
Yeah, I'll stop sharing, sir.
Is it working or we have to wait?
You can go ahead, sir. I'll
Then
stop
you can,
sharing, sir. Yes.
You can
Yeah.
stop screen sharing.
Yeah. I'll stop, sir.
So thank you, sir, for the wonderful presentation. It is a topic which we rarely discuss in usual CMEs. So various aspects of the freedom problem in neurological impairment children you already mentioned. So mainly concentrate on cerebral palsy, but if you think about the condition like acute encephalopathy, nowadays encephalitis and also very common. So initially we have to start with tube feeding. Then you have to, so it may be affected both acute and chronic patients also. I think we have to consider acute patients also in sometimes Guillain-Barré syndrome, encephalitis. Is there any questions in chat box? One or two questions may be permitted. There's no question as such in the chat box. Any
appreciations?
Yeah.
Thank you, sir.
So how will you tackle the, you mentioned some points, but how will you tackle orofacial dyskinesia? That's a very important problem. Other things you can tackle. Orofacial dyskinesia is a big problem. How you used to give any stimulation? You mentioned some technical stimulation about around mouth, everything you mentioned.
Yes, sir. Because one to another, because of the sensory cortex is closer, if you would simulate one, the other is also activated. So one has to be very careful placing the sensory motor, as I said earlier, by the lip closure and so on. You can place your thumb and you can stimulate your show the persistent, the grasp reflex, which is also there, tend to probably release it slowly, and you can show the face, hand to the face of, towards the face of the child, and you can tend to probably increase the coordination, for which only the technique of the physiotherapy also matters and plays a little bit of role, sir.
We have to individualize the treatment for each patient. Each it may be something different. So since we are running short of time and there is no further questions, We'll stop the session here. Thank you, Dr. Anand and Dr. Jayaraman sir for the wonderful opportunity, and thank you, Somsher sir, for the talk. Thank you. Over to organizers.
Thank you, sir. Thank you so much, Shiva sir, and thank you, Anandageshwan sir, for that excellent session. The best is yet to come. We have the theme oration by Dr. Elizabeth Madam. We have the working pediatricians' nightmares, obesity, and the picky eaters to come up. But we'll take just a very short break of 2 to 3 minutes for a cup of coffee, maybe. And we are very sorry that we can't provide it to you. But we'll be back after 2 to 3 minutes. Please stay tuned to us. Thank you.
Please allow me to play the video in between. If anybody wanted to see, can see.
Yeah. That's a good idea.
Yeah. Okay, sir. Thank you.
Tea for us.
But,
yeah, it has come now.
For a nutrition conference, you should provide something. Nutrition conference should provide something.
You able to see my screen, sir?
Yeah.
Yes, sir. Yes. We are able to see your screen. Sir, sound is not audible. Maybe you can remove your earphone from the laptop.
Oh, Kanna. Enema, notes ezidu.
Thank you, sir.
Anand, can you play some music for 2 minutes?
Yes, sir.
Please don't leave away. The sessions are continuing within a short pause.
No voice, no music.
Madam, it's not working.
Then we will continue with the session.
Okay. So welcome back to the second session. Adira madam.
Yes, yes. We are moving on to the main attraction of the CME, that is the theme oration, feeding smart right from start. And who else to talk on this? But else the name that comes to our mind whenever we hear the term nutrition. Elizabeth Madam will be the faculty to talk on feeding smart right from start. And the chairpersons are Dr. Sri Prasad TG and Dr. Kristen Indumadi. Dr. Sri Prasad is the president of the Nutrition Chapter IAP Kerala. He is the president of IAP Alappuzha. He has been the secretary to Nutrition Chapter IAP Kerala for 2019 and 2020. And Dr. Kristen Indumadi ma'am is a senior consultant neonatologist and pediatrician at the SUT Hospitals, Trivandrum, Kerala. She had been the president of Nutrition Chapter Kerala 2020. So I welcome both the chairpersons to chair the session, and I invite Dr. Sri Prasad to introduce the speaker. Over to you, sir.
Thank you, madam. As you all know, the theme for this year Nutrition Week observation is feeding smart right from start. To deliver the theme oration, we are fortunate to have our own celebrity icon, Elizabeth Madam, our own favorite teacher. She doesn't need any introduction, but as the president, it's my responsibility. And at present, Madam is the UNICEF consultant of Kerala. She was the former professor and HOD of pediatrics and superintendent of City Hospital, Trivandrum. She was the past state president of IAP Kerala in 2016. She was the past national president of IAP Nutrition Chapter in 2017 and 2018. She was the university first rank in MBBS with 3 gold medals. She's the author of so many books, including Nutrition and Child Development, Pedi Bloom and Pedi Notes. She wrote many chapters in so many PG books. I think you may all have read it. She's having 228 national and international publications in her credit. She got 14 awards so far, including Best Doctor Award by State Government of Kerala and in 2014 and Best Teacher Award in 2013. Now I request Kristen Indumadi Madam, the past president of Nutrition Chapter, to chair the session. Over to Indumadi Madam.
A very good morning and greetings to all. Welcome to this conference. Respected Jayaraman sir, MKC sir, Elizabeth Madam, Sukumaran sir, and all the stalwarts of IAP, Sri Prasad, and all the distinguished faculty who have so nicely joined us today, all the pediatricians and delegates. At the outset, I thank the organizers for giving me this opportunity of sharing this session. And nutrition is such a wonderful conference always to me. And the theme for this year, of course, as all of you know, is feeding smart right from the start. And we all know that nutrition is the very basic foundation of health. And we are coming to this again and again and realizing that we are not doing the right things. So eating the right from start is very important. And with the launching of the BFHI, revamping BFHI Kerala, starting right. But where are we heading? And it is our responsibility, I feel, as pediatricians, as doctors, that every time a child comes to you to inquire about the breastfeeding status or the nutrition of the child, whether it be an immunization program or is it in the OP or even if it is in the ICU. So as a responsibility, let us take it up. And to enlighten us on this theme is none other than our own madam, who is, as Sri Prasad has introduced, she has been the pioneer and leader and encouraging us. Everybody forgets about nutrition. Madam is always there that you are telling us about nutrition and the importance of nutrition for the children. So with this, I invite Madam to give a narration on the theme. Thank you, ma'am.
Thank you, Dr. Sri Prasad and Dr. Indu for the kind words. I salute IAP Kerala, Dr. Jayaraman, Dr. Johnny, and IAP Nutrition Chapter, IAP Palakkad, Dr. Adira and Dr. Anand, NNF, and respected seniors, esteemed faculty, Dr. Bakul Parekh, Dr. MKC Nair sir, Dr. Sukumaran sir, Dr. Srinivasan sir from Pondicherry, Dr. Andakeshavan, and all of you. So I consider this as an honor. I think the screen share is not working for me. I am seeing your screen. Stop share. Somebody's screen I am seeing. Organizers, please help me.
Make madam as
Okay,
host.
madam. Okay, madam. Madam.
Another screen is coming when I'm.
Madam, now please share, madam.
No. Let me try again. No. I'm seeing the screen of the organizers.
Madam, now please share, madam.
No.
Madam, host akile.
One minute. Madam is actually co-host now.
Yeah, I was co-host.
Let them stop and then do it again, perhaps, and open the PPT and keep it now.
It is all opened and kept.
You can do it once again, maybe it will come.
I am seeing on the screen, I am seeing Hindu now.
Is it? Okay.
Select a window. That window I am seeing.
Madam, now you try. Now you try, madam.
Something.
You try again, madam.
We can see you. We are hearing you. So
yeah, I can see you, but I am again now. I am seeing Dr. Anand's screen.
Okay. Then, madam, slides have been sent. Then somebody can share.
1 minute, madam. No, madam, please once more you try.
No.
I will make you host.
Anand, if your screen is so, you shared anything, you stop it. Anand.
Actually, now I am not sharing anything, sir. Can anyone else see my screen now?
You make her host.
Yes, I will do it now.
Then she can share.
Madam, I have make you host.
Madam, the fourth madam, out
I think you can go with the next session and then I will come back because
okay.
I'm seeing now Sri Prasad's screen. I don't know what it is.
Sri Prasad's screen. Madam, you are the host now, madam. You can.
Share screen, madam.
Share screen is there. When I'm taking the share screen,
okay.
I'm seeing Sri Prasad. Okay. I think let the next presentation.
Madam, screen adil tottittu share koduthu nokku madam. Appo very down. Madam screen le samsarikkunna aalde photo varunadayirikkum. Yeah, it's now coming. Thank you. So now,
madam, can you make me the host now? Otherwise, you will not be able to. Your topic will be interrupted. Participant list. Okay. Okay, madam.
Madam, slideshow.
Madam, please unmute. Madam, please unmute.
Madam.
Am I audible now?
Yes.
The host had to give that. So I'm extremely happy and privileged to give this theme presentation on feeding smart right from start. And I was trying to recollect what happened in the previous years. From 2000, when I go down the memory lane, I could recollect that from 2000 onwards, I was doing this Nutrition Week celebration and pulling up one gastroenterology, endocrinology, genetics like that. Until 2008, it went on like that. And then I was doing a lot of UNICEF workshops. Maybe I have come to all the medical colleges and most of the district branches for zinc and ORS, this RCH kit, IMNCI chart book, IYCF, and so on I was doing. And then lot of when Dr. Sachi also prompted, we went to Attapadi to start the first NRC there. And in 2011, with UNICEF support, we made it a state conference. So this is the 11th pediatric nutrition conference which we are having. I'm audible, I hope. And
Yes.
that time we made the State of the Kerala's Children 2011 one presentation, and it said that we have to concentrate on the congenital heart disease back. And am I audible? Again, I was.
Yes, madam. Yes, madam. Yes, madam. Now
Okay.
you are audible. I have muted all other parties.
Okay, so that is the story. So 2000 onwards, we are celebrating the Nutrition Week, and I remember every IAPNs used to travel all the way to Trivandrum to listen to this nutrition meetings. And every child, as the United Nations Convention of Child Rights says, has the right for survival and quality of survival. Every baby has the right to grow up happy and healthy like this. But unfortunately, some of them end up like this, and many of them end up like with obesity. And so our concern, especially in this COVID era, both malnutrition as well as overnutrition or obesity and overweight. We should not call it overnutrition because they also have a lot of deficiencies, say iron, iodine, zinc, etc. And look at the sedentary habits and the overeating habits of the children. They are looking, when they are coming together, they are not talking to each other. They are only eating and watching the TV. And see how the shape of the children changed these days. And I'm very concerned about that. That is, see the apple shape and pear shape we used to see, but now the pillow-shaped children we are seeing. This is of great concern. And after 10 months or 12 months, when I see the same children I was seeing, they are 20 kilo, 10 to 20 kilo excess. And everybody thinks that is normal. The normal children are all considered as very small and failure to thrive. And you know, when it comes to the hidden hunger, India was in the severe group. That is in 30.3 is the hidden hunger. Hidden hunger index is calculated by looking at how many people are iron deficient, vitamin A deficient, and zinc deficient. And zinc deficiency is taken because that indicates the stunting weight. See what happened later in 2013. We moved to the alarmingly severe state. That is, it became 48.3. So that is why we have to now talk about feeding smart right from start. And if you look at the Comprehensive National Nutrition Survey 1618, you can see that the green line, that is, as age advances, what is the stunting is going up, and the underweight is going up, and the wasting is almost static, that we can see. And what did NFHS 4 and 3 reveal? Look at the last line. If you can see, that is Kerala. 93.9% of our children were receiving solid and semi-solid food at 6 months. And now there is a minus 30.8. And this is of great concern. And that is why we have started the complementary feeding day also. And the NFHS 5 data, if you analyze also, there is not much improvement with respect to Kerala. And we know you are what you eat. It doesn't mean what I eat now, what I got during my first 1,000 days. It is -9 to +24 till the second birthday. And you see here, is it really from consumption? Or look at this, the epigenetic imprints on the fetus is happening when the fetus is in utero. That is, this fetus is going to give the offspring using the ovum, which is having the epigenetic imprints, which is when the ovum, the fetus was in the grandmother. So now it may take 3 generations for us to get the benefit. That is the thing I want to tell you. So it is actually pre-conception onwards, it is coming. And by 2 years, 20% of the weight, 50% of the height, and almost 75 to 80% of the brain growth is happening. And after 2 to 3 years, the window period is gone. After that, the neurons cannot divide. Only the glial cells can divide. And see this pruning. What is this? By 2 years, the connections are maximum. Then 2 to 4 years, I would like to all of you to look here that some pruning is happening. If the child is not using many of the senses or is not learning by asking questions, the why, what, when, how, like that. They are all learning from the mobile or from the TV channel or some children's program only they are watching. See, their brain connections get pruned. So the pruning is starting from 4 to 6 years. And that is why we call up to 6 years is the formative period. You have to keep your connections live. Otherwise, the brain which is not, the part of the brain which is not utilized is going to get pruned off. This is one important thing I want to stress. And when we were students, we were taught that 10 to 12 kilograms weight should be gained by the mother. But you can see that it way back in 1999, it was said that the weight gain should be according to the BMI. Are we teaching our students like this? Still, I wonder. And in 2009, they have revised it. So this information should go on. An obese mother need not gain 10 or 12 kilo. It can be restricted to 5 to 9 kilograms. See that. And this golden hour physiology and psychology has attracted me a lot. See, a baby is passing through 9 navaresangal, I will say, when the baby is born. The first is the birth cry. Then they relax. That is, they relax and rest on the mother's abdomen. And after that, the baby will awaken and the baby next get to an activity. Then at that time, the baby may look at the mother's face even. And then there is again a rest period. And after that, they are ready to crawl. Then they familiarize. What do they familiarize? They familiarize the smell, the vision of the mother. We can see that picture there, the familiarizing on the lower quadrant. You can see how the baby is familiarizing with the heartbeat of the mother, with the voice of the mother, the face of the mother, and even smiling, I can see. And then the baby will suckle, and after that, the baby will go to sleep. And are we doing the right thing? We cut the cord immediately, and we don't even allow the enough blood, oxygen, and iron to get into the baby, and we cut it and then take off the baby. And this period, this is what we are missing. I think this is alarming. That, and immediately if you put the bottle or even the nipple, mother's nipple or areola to the baby's mouth, baby is not ready at that time. And I think recently our dean's baby was born in our hospital, and I was watching the baby doing this. Actually, I saw all the navaresangal in that baby. And this is from the original paper which came in Acta Pediatrica, the birth cry, the relaxation, awakening, then an activity that is searching for the breast. And then again, they will rest, and then they will crawl, they will familiarize, then suck. And we have to capitalize on this. And when in the second stage of relaxation, the baby has got all the hormones in such a way that the pain is less. And that is the time they recommend for giving vitamin K and vitamin, perhaps hepatitis B injection. That is soon after the birth cry. And when they relax, you can give. We may be, when the baby is familiarizing, we may be giving the injection. When the baby is resting, we may be pushing the breast tissue into the mouth or the bottle, telling that, or when the baby is sleeping, finally, we may be giving it. And so this is the paper I was telling, 0 separation between the mother and the baby. That is what we should be aiming at. And breast milk is not only a nutrition, it is for brain growth, emotional growth. So 0 separation unless critically ill, and 0 alternate feeding unless medically indicated. And this first hour skin to skin contact is different from KMC. KMC is what you give for subsequent weight gain. Maybe till they cross EDC or 2 kilograms, we may give it. It should not be understood as the KMC. But when the baby is in the active phase of crawling, we should see that the mother's bed is big enough and some pillows or towels are kept on the side of the mother, between the mother's body and her hands, so that the baby will not slip and fall down. And what happens during lactogenesis? And in lactogenesis 1, under the effect of the hormones, the mammary gland prepares and starts the secretion. And then comes the lactogenesis 2, soon after birth, 30 to 40 hours normally, but it may take up to 72 to 96 hours if it is a cesarean section or there is a lot of stress involved, lot of pain involved. So there may be a delayed lactogenesis. And if you tide over that period and early initiation within an hour, that is when the baby is ready. That physiology should be in our mind. That psychology of the baby and the mother should be in our mind. And after that, from the 3rd day onwards or so, there is copious milk production. And at that time, there is an autocrine local control. What does that mean? If you don't empty, the brain will say, stop producing on that side. But the hormones may be working, like prolactin and oxytocin. And see, the oxytocin and the prolactin is going to come in pulses when the baby is feeding. So if you don't allow frequent sucking, this may not happen. And see, this is what noradrenaline is 10 times higher at birth than ever again. And the high levels of noradrenaline ensure early bonding. And the baby is now has a flavor bridge also. The baby, whatever the baby had smell of the amniotic fluid, the same smell is there for the breast milk. And the mother's diet is also influencing the flavor bridge of the baby. And see, everybody is afraid baby may need 20 ml per kg, 30 ml per kg per feed, or even 200 ml per kg per day. No, on day 1, the physiology is such that the baby's stomach is only like a cherry, and 3 days walnut shape is there. And no other mammal has a baby who is clad with so much of fat. If glucose is the primary the energy, but we can use the fat also. See the animal kingdom, learn from the animal kingdom. They are all not clad with so much of fat. A human being the highest creation, even if there is an adversity, we have enough fat. And these are physiology which we have to learn. And recently, people are telling the breast anatomy is also different from what we learned. There is no lactiferous sinuses, they say. It is the nipple and the areola is one unit which will go right into the baby's mouth as a teeth. And we were thinking of a lactiferous sinuses because we were injecting some dye and there was no letdown at that time. The letdown is happening by the baby sucking or by the oxytocin. Maybe in cadaver and all we did. And so the dye was getting pulled like a sinus there. There is no sinus is there. That is the latest understanding. And it is going like a teeth right into the baby's mouth and the baby is suckling. And we have to capitalize on the hunger cues. And if a baby is crying, if the baby is first opening the mouth, turning the head, then stretching the hand, taking the hand to the mouth, then crying, we should not allow to that period to go. It is not a scheduled feeding. It is not a demand feeding. Some babies may not demand because they are too sick or they are hypothyroid or less active to demand. But when they will be opening the mouth and giving you the cue that the baby is ready to feed. So, and if a baby can show the cue for feeding, the baby can also give the cue that tummy is full. A young infant unlatching from the breast, turning the head away. In an older infant, they may stop feeding, they may spit out, they may push the spoon, they may start to play with the food. That is the time. And no meal time, as Dr. Somashekar was telling, should continue more than 30 minutes. And see, why do they become picky eaters? And there is a lecture on that. See, that is pressurizing. That means they rebel. And sometimes, and we may be the unindulging. That is, the baby is given everything, baby will spill everywhere. This is also not good. See, neglected. This a bottle is given, the father is doing the other work. And why can't we make it very attractive to the baby? That is all the favorite animals or birds or whatever is there in the nature. So we should give it attractive, and it should be a family happy time, a home time for the feeding. It should not be in front of the TV, etc. And what do we learn from the animal kingdom? That baby is given species specific milk. That is one thing. Second, the mom is very passive. The baby has to smell or feel and get onto and latch onto the breast. And this is possible for our baby also, provided we keep the baby prone on the mother's upper abdomen and chest. But we keep them supine in the most helpless way and say baby is not feeding. And what is best for the baby? Dr. Ubendra has also talked about it. Mother's own milk. It may be direct breastfeeding or express breast milk. Then PDHM. What is that? Pasteurized donor human milk. Then comes formula. So it is our duty to see that we have lactation management units, or at least lactation support units for ensuring these things in our maternity hospitals. And family participatory approach is what we should be doing. We always give the class to the mother. And when the mother is there, maybe a bystander, maybe a hired lady or a neighbor or a friend or a sister may be coming, but she is not an opinion leader. It should be a family participatory approach. We have to tell them about the benefits of breastfeeding. And another thing is that our brain is not very sensitive to long-term benefits. If you take breast milk, your baby will have this. If you tell long-term benefits, we are not bothered. Immediate benefit, we should say. The bilirubin is going to come down. Your baby can be taken off the phototherapy unit. Your baby can be off the IV fluid if you feed. Baby can maintain the glucose like that. And they are very sensitive to the dangers of infant formula. I think more than the advantages of breastfeeding, we should be telling about the disadvantages first. And this is the flavor bridge I said. And the 5 taste buds are there at birth. Taste, that is sweet, sour, bitter are there. And the salt is coming by 6 months. So that is why we say that we have to go a little slow on the spicy food and all. But sweet, salt, because amniotic fluid is salt, bitter, the baby can take up. And this Priscilla Dunstan has said that baby communicates with 5 phonations. And how is it? We have 5 senses. Similarly, they have 5 noises which they make. See, if they make a noise with the lip, nay, like that, if they cry, it is for hunger. Oh, if they cry, we say, oh, it means sleepy. Hey, 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 if they cry, it is discomfort, maybe some pain somewhere. That means, please birth me. Upper air is there. Air. Sometimes they cry, that is lower gas. I think they have their own language. They have their own emotions, and we should learn that. And previously we used to say that amniotic fluid is sterile, placenta is sterile, meconium is sterile, human milk is sterile. Now we know all these are steaming with bacteria. That is the Homo sapiens. We have more bacteria on our body than our cells. And they belong to the firmicutes, bacteroids, Acinetobacter and proteobacteria. And the proteobacteria are pro-inflammatory. So we don't want them to be pro-inflammatory so much on our body. We want the firmicutes and bacteroids to balance it. That is the anti-inflammatory. And the gut communicates with the brain, and it affects your behavior and your CNS effect. And in fact, we say our T cells get university educated in the thymus. But I must say the primary education is in the breast. That is the enteromammary axis, the gut associated lymphoid tissue and the lung or the bronchomammary axis. So the primary education of the T cells is happening there. And 80% of our immune cells hang around the gut. So what you give to your baby is most important to decide the immune function also. And when you have altered bacteria in your gut, the TH, that is the T helper, one pathway may get accelerated, leading to autoimmunity and Crohn's disease. If the TH2 pathway gets accelerated, there can be a lot of allergy and asthma. So that is it. So breastfeeding is for self-regulation, it is for growth, it is for the good microbiota and a healthy infant and healthy future. So what is happening is that we tend to separate the mother and the baby diet. We diverse them. And so what is the answer? We should have MNICUs, that is mother neonate ICUs we should have. And then the BFHI hospitals should become mother and baby friendly hospitals. We should have lactation management units. And the government of Rajasthan said no discharge until the baby is empowered for direct breastfeeding, whether it may be days, weeks, or months. I salute them for doing this. And then who is there to handhold in the community? Or it is who will protect breastfeeding? It may be the father, the decision makers in the family, the opinion leaders in the community, the employers. They have to protect. That is, we have to start the MA program. Mother's absolute affection should be given to the baby. And then what happened? Then comes the 6 months rice giving ceremony. It was there, but we never promoted that because maybe previously the complementary feeding was started at 4 months. So 1.5, 2.5, 3.5 months immunization visits were enough for our pioneers to tell them about how to start the complementary feeding. Now we pushed it to 6 months because it is the ideal one. But what advice are we giving? At 3.5 months they come, and after that they come at 9 months completion. By the time all the wrong practices would have been gone in. So we have to make the right at the right time, the bridge, and the bridge should be made strong enough. That is continuing breastfeeding, etc. And breast milk will give you 70 kilocalories per 100 ml. And the complementary feeding should be isodense, I will say 100 kilocalories per 100 ml. But very dilute formula when you give, it is only 30 calories. That is what we have to. And the 6th day of 6th month, and I must congratulate IAP, National IAP for giving this day as the complementary feeding day, as we suggested from the IYCF group. And previous speakers also were telling about it. What to give? Search at home rather than in the supermarkets. And in stage 1, I will say 6 to 8 months is stage 1. And you give very soft food. Pureed, that is, maybe we are giving cereals, slowly pulses, roots, tubers, or vegetables, cooked vegetables or fruits, like that, very soft. And 8 to 10 months is the time when you can give lot of little more lumpier food, and you can introduce non-vegetarian items like that. And 10 to 12 months, the baby has pincer grafts. Give them finger-shaped long pieces so that they can hold and also start eating. They will have teeth also by that time. No added extra sugar or salt is needed because they are super tasters. Their taste buds are very close by. So if you give them lot of sugar, they get attracted to that, and lifetime they want lot of sugar. If you give them very salty food, they may get attracted to that, and that is why we don't want. And due to lack of time, I'm not going into all the details. There are 6 R's that you have to speak about responsive feeding during complementary feeding day. Right age, right place, right time, recognition of feeding cues, reciprocating to the baby, respecting the infant, reinforcing all the positive behavior and ignoring all the negative behaviors, and becoming a role model in healthy eating. And so media-free time, media-free zone, comfortable seating should be. And what is the consistency? and that is, it should not fall off from the spoon. And don't miss breakfast. Five times, five food groups, 5 colors in rotation to a toddler who is a very poor eater. And the rainbow diet. And then reading the labels. How much sugar is there in the lassi that I took, or in the fruity that I'm giving to my baby? How much trans fat is there in the frozen dessert? How much sugar is there in the complan which I am giving, thinking that it will give some protein to the baby? And how much energy is going when I give my baby one McDonald's? So that is what we have to. And about the junks, we should know. And 100 gram, 100 kilocalories. That is the traditional diet. Whereas now we are doubling it because we are adding all the trans fat to it. And drinking water. And in schools, there were bells for drinking water. Now, who will ring the bell for the water drinking at home? We have to encourage our children. Give them, this is your measured volume that you have to drink. That is what we have to tell them. And about fiber, because constipation is the rule now rather than the exception. And then we must teach them about that iron. It is iron that makes you shine. Don't go behind the gold, and invest in your iron rich food. Then iodine, double fortified salt also is there. And this type of vitamin A deficiency we may not be seeing, but ask for night blindness. That is when power cut is there, we can't, none of us can see. But after some time, our eye will adapt. Dark adaptation will come and we can see everything. So when my grandson, the younger one was a little fussy eater, so the elder one drew this for him. That is, the bunny was playing, and the bunnies, it got late. But bunny was playing his hero, that is the Superman. And his mother came and said, "Bunny, you go and fetch something from the field." Then bunny started crying, "I have night blindness." Then the Superman brought some carrot. Bunny ate it and he got cured. And such stories, bedtime stories can be there. And zinc deficiency is the rule. And so at least when there is diarrhea, we should be capitalizing on 2 weeks of zinc. And hypovitaminosis D is a lifestyle disease. And UVC is present at any time from the sun. It is good for, that is sterilization. UVA is the one which is coming in the early morning, which is good for phototherapy. It is not good for the vitamin D synthesis. It is the UVB, which should fall on our body with minimum zenith angle. That is why it is 11 a.m. to 2 p.m. But I see that many speakers say early morning sun is enough for vitamin D. And then this is something I would like you to pay your attention to. That is, we should not go beyond the tolerable upper limit, UL, which is much above the estimated average intake and the RDA. And after that, there is some side effects happening. Look at folate. It is only 1000 microgram, 1 milligram. Why are we giving 5 milligram to all our non-risk, high-risk mothers also? 4 milligram can be given to high-risk mothers, but we are giving it. And vitamin D, 60K every week. It is only 4,000 for the adult. That means we can maximum 60K, 2 are enough. And look at iron. The tolerable upper limit is only 45. We were giving 100 milligram. Now, luckily, we have come down to 60 milligram. And omega-3, what is the mother should take a lot of fish, but what about vegetarians? Leafy green and walnuts, beans, chia seeds, mustard oil, rice bran oil. These are the omega-3 sources for the vegetarians. And we must teach our children, they have to take food. Don't miss food, because it is for the 3 Gs to go, to grow, and to glow. And it should be a balanced diet. We can't take one pill for every micronutrient. And this is from a vegetable day from the school attached to our medical college. And children can be given these sort of puzzles. Find out the good food, the ladders, more ladders. And then dietary diversity is not working. Everybody is not eating all the food groups. Food fortification is very costly, and supplementation is not working, because for so many decades we have been giving IFA tablets and anemia is not coming down. And United Nations have come out with the sprinkles, that is with 9 vitamins and 5 minerals. They can just add it to their salad and take it. I think this sort of innovations can work. And what is smart? Smart, I will say, soaking. The grain should be soaked so that the anti-nutrients will go and it will become more digestible. When you malt it, that is the sprout is coming, the anti-nutrients will come down and the micronutrients increase. Then A stands for the amylase-rich food and the amylase-resistant starch. That is, we know all the benefits of that. Then R stands for responsive feeding, and T for the traditional practices, that is steaming, boiling, parboiling, sorting, simmering, shallow frying, fermenting. And we know that Paranganji has got, the old rice has got a lot of benefits. And it is said that even when you, the fermented food may have some microbiota, which may be synthesizing even vitamin K. We always say that only non-vegetarian food is the source for vitamin K. And let us go back to our grandmother's tradition. And the amylase-rich food, you can soak and sprout, and then remove the skin, and 70 degree, up to 70 degree, you can roast it. That is, the steam will start coming from there, and it will be now very easy for you to move the grain. Otherwise, water-soaked grain is difficult to move. And what is amylase-resistant starch? The jack green, the green banana, the sweet potatoes, they will not be touched by the amylase. It will go to the colon and get fermented to produce short chain fatty acids, which is very good for your colon health, to prevent constipation and colonic cancers. And so we should teach them, do not reuse the oil. At room temperature, oil is most safe. Then we can rotate the oils, deep frying, coconut oil, shallow frying, maybe sunflower oil, salads, dressing, olive oil, gingerly oil for pickling. Different oils you should rotate, and complement your masala dabba, which is a treasure of antioxidants. And then avoid trans fat. Anything which is solid at room temperature, the dalda, the maida, the animal fat, it is solid at room temperature. And then people may ask, what about ghee? Ghee has only 4% trans fat. And limit the screen time, ensure sleep, and give good exercise. As far as I know, none of the immune boosters are going to work, because what are you going to boost? It is not possible to boost. What are you going to boost? Is it the antibody production? Is it the secretions that you are going to boost? Or is it the cytokine you are going to boost? And that is a myth. And only good sleep, exercise, and food can optimize. Don't go behind all the immune boosters. I think so. Start feeding smart right from the start, and treat them as not as miniature adults. They are children, and you don't treat caterpillars as small butterflies. Thank you very much for your patient listening.
Thank you, ma'am, for that wonderful presentation.
Thank you.
Madam, please, you can continue.
Madam, you're muted.
Madam, please
Yes,
unmute.
yes. Madam, thank you for that beautiful message. The slides and everything is conveyed so beautifully. I think we can't forget your message. It is well done. And very rightly said, we have to start right. And definitely, I feel the next generation, as we all work together, we would be creating a better generation who's really thinking of nutrition. I think many of the people are asking about nutrition nowadays, and we are all aware that I think some parents are in fact complaining that the children are unwell. They think something is wrong with the child, some edema. So actually there's the obesity, they're coming back in this COVID era and they're coming and saying the child is unwell. So that itself should make us think, that every time we should be talking to them about nutrition. And thank you, madam, for creating that thought in us, in all of us. And if there are any questions, you can take it.
Madam, I am having one question to you.
Yeah.
At what age can we add sugar or salt to a baby? At what age?
There is no need for added sugar, but I think when you prepare, you should, we always say, kannanirinte uppe agavullu. That is that much. So maybe we can take off. I don't believe that we should take everything bland to the baby. We are empowering to family pot feeding. And some people say, don't give any even cow's milk before 1 year. Maybe in asthma allergy family, I advise that, like IAP. But here in India, it is a calcium and a protein supplement for our baby. And will you not give ice cream to your 10-month-old baby when all of you are taking ice cream? Can you refuse to a 10-month-old baby? It's not possible. So we should be liberal with them and we are empowering them, but they are super tasters. So with one dosha, if I give 2 spoons of sugar, every time they will demand that. So we have to be careful.
Now, what is your choice, Sharkara or Kalkandam for mixing?
I think both are good depending upon how good it is. If it is not adulterated.
Anyway, now that the juices have been taken off, isn't it, madam? Juices are not advised.
No, juice is not. They should take the fruit as such.
Yes.
Madam, you have told about starting non-vegetarian diet at 8 months. Is that?
I am recommending like that because, by the time all the taste buds are there and they can coordinate smell, vision, smell, and even the feel with the food. In the Western world, people give soup and all even at 6 months.
Yes,
There is no harm. There is no harm.
Okay.
There is no harm. But if we say that we can give non-vegetarian at 6 months, it is not very acceptable to our community. So I say 6 to 8 months, let us start all the vegetarian food groups, and 8 months, let us start. When they are more ready, they can sit up. Now, no, they can sit up and enjoy the food. There is no harm in giving earlier also.
Okay,
Yes,
madam. Thank you.
Madam, you have told us about the stomach capacity.
Yeah.
The
stomach capacity. Can you complete the question?
If you are in a situation, we have to give some EBM or some formula. How much we should give? What should be the volume?
No. Don't go by the stomach capacity 20 or 30 ml per kg on day 1. It is, they were not surviving on food from from the mother, no. They were surviving on blood nutrients. So their stomach is small. It has to slowly become big and adapted to it. It is all how we can, whatever is available, maybe 1 ml, 2 ml. So 40 ml of colostrum may be all what they need for day 1. But you have to sing a song of stops for the baby. That is sugars, sensorium, oxygenation, perfusion, and all that. So anything is wrong, you intervene. It is a medical indication to intervene. Normal babies may not need.
Thank you, ma'am. I think maybe for time, lack
Thank
of
you,
time.
ma'am. Thank you.
Thank you so much
ma'am.
for this.
We'll go to the next session. It was an excellent session, ma'am. Thank you very much. So we are going now to the other end of the spectrum, that is obesity. The faculty for this talk is Dr. M. Vijay Kumar and the chairperson is Dr. Riaz. Dr. Riaz is the associate professor in the Department of Pediatrics, Government Medical College, Thiruvananthapuram, and he has got his postdoctoral fellowship in pediatric and adolescent endocrinology. Over to Riaz, sir, for the chairing the session and also to introduce the speaker.
Thank you. Actually, it is indeed a great pleasure to introduce Vijay Kumar sir. Vijay Kumar sir actually doesn't need any formal introduction to our members. He is currently the professor and HOD of pediatrics at Mancheri Government Medical College, and he is our president-elect for the next year. And he has been the past secretary of Indian Society for Pediatric and Adolescent Endocrinology. He is author to many chapters and various textbooks in pediatric endocrinology in our country. And actually, I should say that he is our team leader of pediatric endocrinology in our state. And with his efforts, we are able to give a lot of goodness to the patients, especially the patients with diabetes, growth hormone deficiency, etc. And the topic which he is going to discuss today is also important. Elizabeth Madam has also touched upon that because even in our clinic, in endocrine clinic, now I think obesity is replacing hypothyroidism as the most common reference. So over to you, sir, for your lecture. Thank you.
Thank you, Riaz, for that kind introduction. And before going to the talk, let me thank the organizers, Dr. C. Prasad and the team for giving me a chance, and IAP Palakkad for giving me a chance to discuss a very common malnutrition in front of you. So, can you see the slides?
Yes, sir. We can see the slides.
Yeah, and you can hear me also.
Yes, sir. Yes, sir.
Thank you,
Very
Anand.
clearly.
Yeah. So, what is the importance of the other spectrum of malnutrition, obesity? That is now one of the most alarming public health issue. And the most important thing is that childhood obesity tend to track into adulthood. If the child is obese, he will be an obese adult. And majority of obesity and its comorbidities in adulthood has its origin in childhood. So, and another important finding is the obese children who lost weight and become a non-obese adult do not have the increased risk of obesity related mortality and morbidity. So, it is our aim to diagnose or prevent obesity, diagnose obesity in childhood as early as possible, and to treat it so that he will become a normal non-obese adult with less comorbidities. So, the prevention and treatment of obesity is a pediatric goal. So, I will move with three sections. The section one is predisposing factors. So, there are three factors that affect overweight. So, one is genetics, one is eating pattern of the child, and activity pattern. So, everybody knows that genetics is very important. Even if you are thinking in terms of monogenic obesity and the obesity in syndrome like Prader-Willi syndrome, Laurent-Moon-Biddle syndrome, but even in a normal exogenous obesity, there is a genetic background. So many of these things are not elucidated, but since we can think that there is a genetic background, but that cannot explain the epidemic or the pandemic of obesity occurring nowadays. So along with genetics, the eating pattern of the child has changed a lot, and the activity pattern of the whole family has changed. That has created to the epidemicity of the pandemicity of obesity nowadays. So what are the most vulnerable period of obesity? The three most vulnerable period of development of obesity is, one is prenatal period. That is 90% of fetal fat deposition occurs in the last trimester. Another age group is infancy and the toddler age group. The fat deposition account for 50% of the total weight gain. And the third is during adolescent growth spurt. The age after the toddler age group, that is 4 to 6 years, is called as a lean period, so that at that time most of the parents will tell you that my child is not getting weight and all. So what are the predictive factors of obesity? So first and foremost is the birth weight of the child, and it has a U-shaped relation. If the birth weight is more than expected, there is a high chance that the child will grow as an obese adult or adolescent or adult. But and if the birth weight is very less, that is seen in SGA babies, they are having high incidence of metabolic syndrome. So prematurity and SGA babies are having increased incidence of metabolic syndrome. And the gestational diabetes is a very important factor that will produce later overweight and obesity. Some neonatal complications like CNS injury can damage the hypothalamus and can trigger as a focus that will produce obesity later. Artificial feeding. Incidence of obesity in children never breastfed is 4.5%, and the children on exclusive breastfeeding is just half of that. And the duration of breastfeeding, that is inversely proportional to obesity. The more you breastfeed, less will be the obesity in the child. And the weaning. Early weaning is having a bad influence on the weight gain. So the early weaning can produce obesity. And the type of complementary feeding, you can see that this type of complementary feeding like ragi, that will prevent a child from getting obesity, unlike this type of feeding like. So what is meant by adiposity rebound? Whenever there is early adiposity rebound, the chance of overweight and obesity is very high. You can see this growth, this is body mass index chart. You can see that the body mass index is least at 5 to 6 years. And after that, gradually the body mass index increases in a normal child. This is called as adiposity rebound. This is the adiposity rebound immediately after the lowest body mass index at 5 to 6 years. But if the one strongest predictor of adolescent obesity is a rapid weight gain between 2 to 6 years of age, that is called as early adiposity rebound. So if the adiposity rebound occurs a little bit earlier, that child will produce overweight and obesity during adolescent age group. If you ask me which is the most important risk factor for childhood obesity, I will tell that that is the parental obesity. If the parent is obese, the child will be also obese. What are the factors that will affect it? One is genetics that we have discussed, and eating habits of the parents and activity pattern of the parents. What are the abnormal eating habits that result in obesity? One is skipping the breakfast. That is the most important problem that will produce obesity, especially our children are going to school. They will wake up late and they will skip breakfast and they will be always hungry and they will take junk foods from the school and all these things. And the skipping of the breakfast is one most important predisposing factor for obesity. Then eating while watching TV. Third important thing is increased portion size. Then drinking sugar sweetened beverages, that we have to say no to sugar sweetened beverages from infancy onwards. Then eating junk foods, the high calorie foods that can produce obesity, and avoiding vegetables and fruits in the diet. Another important thing is reduced physical activity. The physical activity is reduced nowadays because everybody is seeking the help of car and motorcycle to go to school, and there are plenty of school buses are there. Nobody is walking to school. Another thing is the study time is increased, that will cut short the time for play. And this poor child is forced to read the textbooks, but he is dreaming about the play he wants to do. And schools are like jails. They are cutting off the time for physical activity, and they are more concentrating on entrance examinations and all these things. And increased screen time, and the living in flats and other crowded areas where there are no place to do activities and play. And in the flat, the mothers are so anxious that they won't even ask the child to go out and play for at least for half an hour. And another thing is altered sleep pattern and stress. Nowadays, our children, they will just, they won't sleep till early morning. We can see that our children are watching TV and they will be having effective sleep time is less in almost all children. So the dictum is, if you snooze, you lose. Whenever the hours of sleep time is less, actual sleep time is around 8 hours in our school going children. If it is coming down to 5 hours a day, the body mass index increases by 3.6%, and the leptin level decreases by 15.5%, and the ghrelin level increases by 14.9%. So when you are just waking up late in the night and reading, you will get hungry. That is because of the increased ghrelin level. And another is stress. They will seek help of some fruits or some candy bar or some sugary foodstuffs to make better. So the stress and the altered sleep pattern will increase the chance of obesity. The second is how to evaluate. Suppose a child comes to you with overweight or obesity, how to evaluate the child. Always we have to seek the help of a growth chart. Without growth chart and body mass index chart, we cannot manage, we cannot evaluate a child with obesity. The most important thing is the height of the child. If the height is normal and the height velocity is normal, you are almost confident that you are dealing with a case of exogenous obesity. If the child is having short stature, you have to think of some endocrine or genetic causes for his short stature. And if growth velocity is poor, so then also you have to think that this child is probably having some endocrine causes as his cause of his obesity. Then the weight of the child. You can see that the weight of this child, this is a girl of 10-year-old girl. Her height is 142 centimeter and her weight is 65 kg. And third important thing is body mass index. So there is an IAP body mass index chart. If the value is above this orange line, that is 23rd adult equivalent. So if it is above that line, that child is having overweight. If it is above this red line, that child is having obesity. So you have to plot in the growth chart. Here in the latest WHO and IAP growth chart, there is a separate column for obesity, body mass index, because you need not even calculate body mass index in this chart. Just take the height of the child. So the height of the child and weight of the child, just you will get a dot. You just put a dot where it crosses, where it meets. You can see that this lowest line is below that lowest line, that child is underweight, and the middle one is overweight. And if it is above that, the child is having obesity. The third important thing is metabolic syndrome. The definition is limited to children above 10 years. That metabolic syndrome is proportional to abdominal or visceral fat deposition. Here, the waist circumference is considered as a good predictor for visceral adipose tissue more than this body mass index. Especially Indians are prone for central obesity. So they will be having a normal body mass index, still they are prone for metabolic syndrome. So in such children, the measurement of waist circumference is considered as a predictor. So insulin resistance is the underlying pathology of metabolic syndrome. Type 2 diabetes, hypertension, hyperlipidemia, coronary vascular disease, all these things are complications of this metabolic syndrome. You can also include non-alcoholic fatty liver disease, polycystic ovarian syndrome. So how to measure the waist circumference? There is a confusion, but the recent National Health and Nutritional Examination Survey is recommending like this. So the child has to stand erect and we have to use a stretch resistant tape. The tape applied horizontally just above the upper lateral border of the right ilium. So here this is the upper lateral border of the right ilium. Here you can just see the mark and you have to measure at that point. So previous all measurements, that is immediate between the iliac crest and the lower rib or at the level of umbilicus, all these things are gone. Now we are using this just above the upper lateral border of the right ilium, and the measurement is made at the end of normal expiration, not in between inspiration and expiration, and the recorded to nearest 0.1 centimeter. And how to, suppose you got a waist measurement, at least two values you have to measure, and if the measurement is less than 1 centimeter, if there is less than 1 centimeter difference, you have to take the average of this waist circumference and take the value. And there are Indian charts are there to know whether it is normal or abnormal. This is made by Dr. Vaman Kadilkar and his group. So we can see that there are different centiles are there. If the waist circumference is above 90th centile, that child is having at high risk of metabolic syndrome. And if it is above 70, you have to wait. That is just like overweight. So this is a 10-year-old boy. His waist circumference is 80 centimeter. So you can see that if you plot it, that is just above 90th centile. So this child is having high risk of metabolic syndrome. So there are charts are available. You can see that 80 centile, the 78.4 centimeter is at the 90th centile. We can use this chart for evaluation. Then if you are doing the clinical examination, what are the things you have to look? Take BP in all cases, and you have to look for signs of insulin resistance like acanthosis nigricans, skin tags, striae, and signs of hyperandrogenism in girls like acne, hirsutism, hair fall like male pattern baldness, that are predisposing factors for polycystic ovary syndrome. And look for the pubertal status. If the pubertal status is late, delayed puberty, you have to think of some endocrine or genetic causes. Hepatomegaly, fatty liver is a common complication of obesity. Look for thyroid enlargement. Look for wheezing, sleep apnea, and tonsillar enlargement. And always carefully look for dysmorphic features. So these are the red flag signs of secondary obesity. One is slow linear growth or short stature and delayed puberty. If it is there, the child is not having an exogenous obesity. Then cognitive impairment, if the child is having mental retardation. Third is if the child is having dysmorphic facial features, abnormal genitals, undescended testes, cryptorchidism, all these things are abnormal. Then if the child is having visual disturbances like retinitis pigmentosa, you have to look for some syndromic causes. Hearing abnormalities. So this child came in our endocrinology clinic with obesity. You can see that there are 6 fingers are there, and he is using big specs. He is having retinitis pigmentosa. This child is having Lawrence-Moon-Biddle syndrome. So this is, in short, an algorithmic approach for obesity. If always take a detailed history and physical examination, including anthropometric measurements. If everything is normal, this child may be having exogenous obesity. Suppose if anything is abnormal, one is poor growth velocity. If the child is short or his growth velocity is poor, you may be dealing with a case of endocrine problems of obesity like Cushing syndrome. If the child is having hyperphagia, developmental abnormalities, dysmorphic facial features, hearing abnormality, visual disturbances, you may be dealing with a genetic cases. You have to look for karyotyping, DNA methylation if the child is having features of Prader-Willi syndrome like that. If the child is having a CNS injury in the early newborn period or infancy, the child may be having hypothalamic obesity and you have to do an MRI. If the child is having very early onset obesity, you are dealing with a case of monogenic obesity like leptin deficiency, POMC deficiency, MC4R deficiency, and you have to do a genetic test. If the child is taking chronic drug intake like corticosteroids, anti-epileptics, antipsychotics, then obesity may be secondary to that drugs. So in short, if the child is having poor growth velocity, developmental delay, dysmorphism, hearing defect, and visual defect, you have to investigate for secondary causes for obesity. Even the genetic causes can produce poor growth velocity. So what are the basic investigation that you do for assessing the comorbidity in obese children? One is fasting plasma glucose and postprandial blood sugar. So if it is fasting is above 100, the impaired fasting glucose, if it is postprandial is above 140, that is also abnormal. And HbA1c also you can do. If it is above 6.5, that is indicative of developing type 2 diabetes. And the liver function test, especially ALT, if it is above 35, the child may be having an associated fatty liver. And do a lipid profile and the triglycerides, LDL, and total cholesterol and non-HDL cholesterol level, if it is more than 145, that also is abnormal. So I will just go through a case scenario. This is an 80-year-old male. He is brought for evaluation of obesity. BMI is in the obese range, and he has brought with him a thyroid function results. His TSH is 9 and his T4 is 9 microgram per deciliter. And how will you manage this child? You think that the child is having slight elevation of TSH. So this is the body BMI chart. His BMI is very much elevated, and this is the child we are referring to. So main problem is he has come for evaluation of hypothyroidism because TSH is elevated, 9 milli international unit per liter. So what is your inference? there may be a mild elevation of TSH with normal T4 in obesity. So elevated TSH is a consequence rather than the cause of obesity. And TSH will decrease as BMI comes down. So, and this condition doesn't require thyroxine supplementation. So if you give thyroxine, the patient's parents will get a wrong notion that this child's obesity is due to hypothyroidism, and they won't give much importance to his lifestyle modifications. So why there is a elevated TSH in a child with obesity? That is believed to be due to leptin mediated increased production of pro-TRX. So from the obese adipose tissue, the leptin is produced that will stimulate pro-TRH and increase the hypothalamic secretion of TRH, that will increase the secretion of TSH from the pituitary. Once the BMI comes down and once the leptin level comes down, the TSH level will come down. So there is no need to treat such cases with thyroxine. Section 3 is how to manage and prevent. The first and foremost is dietary intervention. Food is not a token of love. So always we have to intervene. You have to do family-based intervention and motivational interview. So unless you do a family-based intervention, all our intervention to manage the obesity of the child will fail. And we have to advise the parents that child should take only appropriate calorie intake as per the ICMR chart. And the meal selection should be based on fruits, vegetables, whole grains, lean meat, fish, and less of oils and sweetened juices. And the eating pattern should modify. So we have to encourage family meals. And the well-known traffic light diet planning we have to explain. And the giving different types of fruits, that is called rainbow colored fruits, we have to increase. Another thing is increased physical activity. Here also active participation of the whole family is important. So encourage active participation of the whole family and make school-based physical education mandatory. And the intervention should be long-term. So you cannot just ask them to do increase physical activity for 1 or 2 months, then ask them to come back and take the weight and height. And if the weight is not improving, don't scold them, because weight won't decrease all on a sudden. So it will be, intervention should be a very long-term, sustained and incorporated to behavior modification of the whole family. At least minimum 30 minutes of vigorous activity, at least 5 times a day is recommended. And the limit screen time to bare minimum of less than 2 hours. Now, because of the COVID situation, there is a confusion because of their academic screen time is increased a lot. Then drugs doesn't have much value in management of obesity. So I am not using, or nobody is using drugs, and drugs is not a panacea. And another big problem is if you give some drug and tell the parents that this is a drug for your obesity, they won't give much importance to activity and diet. So one drug used and abused is metformin. That is approved in children of above 10 years. So the child should have indicators of insulin resistance, like impaired glucose tolerance of more than 140 milligram per deciliter, or impaired fasting blood sugar of more than 100 milligram per deciliter, or elevated HbA1c of more than 6.5. Some people will give metformin whenever they see acanthosis nigricans or any obesity they will give metformin. Metformin can give a mild decrease in BMI, but after few months that mild decrease also will disappear. So unless you do a correct physical exercise and diet planning, the drugs will fail. And the drug is 500 milligram BD, titrate to maximum 2000 milligram per day. And at some children, they will produce lactic acidosis, even though that is very rare. Another drug is for dyslipidemia. So when will you start, or whether will you start statins or any other drugs for his dyslipidemia? So always increase the dietary fish content or omega-3 fatty acid fish oil, that will increase, produce some improvement in the triglyceride level. Statins are recommended only on children above 10 years, and the indication is if the LDL cholesterol is above 190 milligram per deciliter, or if the LDL cholesterol is above 160 milligram per deciliter with any of the 2 risk factors like hypertension, obesity, smoking, family history of coronary artery disease, early family death, and family history of dyslipidemias, the familial cholesterolemia and other dyslipidemia, then you can start. So very rarely we could start a dyslipidemia, because if you give good diet and exercise, the lipid profile will improve. So if the child is having combined dyslipidemia in fasting lipid profile, you have to advise regular exercise and low carbohydrate diet, and repeat fasting lipid profile after 6 months. That is based on American Academy of Pediatric recommendation. If the triglyceride is less than 130 and LDL is below target level, continue exercise and diet. And again repeat fasting lipid profile after 6 months. Then if the triglyceride is, even after 6 months, triglyceride is elevated and the LDS is below target, advise the child to increase fish intake, or we can give omega-3 fatty acid. And again repeat fasting lipid profile after 6 months. If the child is having elevated triglyceride and the LDL target is achieved, it is above 190 or above 130 with comorbidities, then you can start one for triglyceride, omega-3 fish oil and statins. And you have to repeat fasting lipid profile after 6 months. If you take this algorithm, the indication of statin is very, very, very low. The other drugs like sibutramine and all these things are not approved in children. And another most important thing is to prevent. How to prevent obesity? To prevent obesity, you have to adopt our old method, how we used to prevent protein energy malnutrition years back. So there should be a regular obesity screening program starting from Anganwadi and primary school level. We should teach our Anganwadi workers, ASHA workers and school teachers how to measure and interpret body mass index and waist circumference from preschool age onwards, and just notify whether if the child is having increased BMI or increased waist circumference. So gradually we have, along with our measurements of mid upper arm circumference and height and other features of protein energy malnutrition, we have to change. We have to even teach our Anganwadi workers to measure, how to measure correctly the body mass index and waist circumference, so that they can pick up the early overweight children and start the treatment programs and preventive programs. Thank you. Thank you for patiently listening.
Thank you, sir.
Hello.
Hello.
Can you hear me?
Yes,
sir.
sir.
Yes, sir.
Yes, sir. Please continue. Please continue.
I stopped it. Thank you.
Okay. Okay.
Sir, you can discontinue your screen share.
Yeah.
Thank you, sir, for that excellent lecture. It's for every pediatrician, treating a obese child is very difficult. As sir has highlighted, the most important thing is prevention. And for prevention also, we are the one who are responsible, because every child coming to us for any illness or any immunization, we have to plot the growth. And when we are plotting the growth, it is not only the height, weight is also important, and also look at the BMI and find out which child is going up the trajectory at a very early age. And then we can advise them and we can prevent morbid obesity. For those who have treated obesity, we will know that it is the most frustrating kind of chronic illness, because whenever we ask them to review with whatever exercise and whatever diet changes they do, they come with a few amounts of few kgs of weight gain. So it is very difficult, and using pharmacological methods in children for obesity also is very difficult. So I think it is our responsibility to monitor these children while visiting us for any disease or any vaccination for obesity and prevent this growing pandemic, I should say. Thank you, sir. And I'm not finding many questions in the chat box. One or two questions. One is like any role of monitoring HDL level.
Yes, I think I forgot to mention or not, HDL level is also having equal importance. So the if the HDL level is low, HDL level is getting lowered. So there is an indication that child is going for, there is lipid abnormalities. And one question is infantile obesity, how the infantile obesity is managed. So infantile obesity is an entirely different entity, because suppose a child is having huge weight gain during infancy, that child may be having one or other causes of monogenic obesity. So you have to, if the development is normal and child is having hyperphagia and obesity, you have to think that this child is having one or causes of just like leptin deficiency, MCRR mutation deficiency. So we have to do genetic study at that time. And if the child is having any features of Prader-Willi syndrome or Laurent-Bodel syndrome also, you have to do genetic study.
And sir, any brand name for omega-3? That is another question.
So there are several omega-3 fatty acid brands, just like Maxtra. So a lot of brands are there available in the market.
Are there any direct questions from the audience?
Sir, as we are running very short of time, maybe the questions can be put in the chat box.
So I'll answer to that chat box questions.
Okay, thank you. So I think we all have gained a lot from the session. Thank you.
Thank you, Vijay Kumar sir, for that excellent presentation, and Dr. Riaz for chairing this session. We are moving on to our next session, the picky eater. We all know that picky eaters are both the bane and boon to the pediatrician. And to how to tame them, we have Dr. Nisha to talk to us, and the chairperson is Dr. Balachandra. Dr. Balachandra is a consultant pediatrician at General Hospital, Pathanamthitta. He has been made the secretary of IAP Kerala for 2019 and 20, and he has been the secretary for ECHGC IAPs 2021-23. So I invite Dr. Balachandra to chair the session and also to introduce the speaker. Over to you, sir.
Thank you, Dr. Adira. First of all, let me congratulate IAP Palakkad, led by Jayaraman sir, Dr. Adira, Anand, Sri Prasad for organizing this conference in an excellent manner. And also thanks for giving me an opportunity to share a session by my close friend. So many mothers say that the child gives a tough time while feeding. The gags when a new food is introduced, doesn't like what all she serves. So these picky eaters, more seen in US, and it is very less in France. And this is one of the commonest complaints, if that kid is not having any, especially when the kid is not having a recurrent medical problems. That is from my personal practice, and more seen in higher socioeconomic class. And psychological problems such as anxiety, depression, hyperactivity, all, and of course the parents also play a major role in this formation of these picky eaters. To solve this problem, we have an excellent speaker who is going to tell us how to encourage a picky eater to eat a diverse variety of food. She is Dr. Nisha Narendran. She is an undergraduate and postgraduate from Toronto Medical College, and now working as associate professor at GMC Thrissur. She is in charge of the asthma clinic for the last 12 years, and she has also a diploma holder in adolescent pediatrics from CDC Trivandrum, and also diploma in allergy and asthma from CMC Vellore. Even though her topic of interest are allergy and asthma and medical research, she will speak on any topic given at any time. And she is also the chief editor of IAP Today and also the associate editor of the Enrich magazine of ECH. So over to you, Dr. Nisha.
Thank you, Balajendra sir, for the great introduction. And let me a warm good afternoon to all of you delegates who are on the Zoom. And let me congratulate the organizers of the conference as well as IAP Palakkad for wonderfully arranging it so fast. And let me thank Jayaraman sir and Elizabeth madam for the chance to interact with you on this platform. So let me share my screen now. One second. Screen is visible, right?
Yes, madam. Screen is visible and you are audible.
We were talking about all signs about nutrition till now. Now I'm going to a topic, picky eating, which is actually regarding where art of nutrition may fail and result in picky eating. So there is a science behind this also. I'll try to explore it also in the very short time given to me now. So there is a beautiful article which came in American Academy of Pediatrics official bulletin in 2020, and they were telling that there is no definite definition regarding picky eating. So what is the issue with not having a definition? It's a very subjective topic dealt with subjectively by all the pediatricians, you know. So, and it's also important to many of the young pediatricians and postgraduates who are attending the program, because you could have a picky eater at your home, and that could be a real trouble, leave alone the patients who are coming to you on a day-to-day basis in OP. So it's a very common topic which we should know and then try to tackle. So there is no definite definition. They are telling like that in the article, and that is true also. So literature is very less with good studies regarding picky eating. This is because of the lack of definition, and they use different type of definitions. Some are very stringent definitions, some are very loose definitions. So what happens when you use a loose definition for picky eating? Are your child a picky eater? The mother will say, sort of, like that she'll be telling. If that is being used as a criteria, the prevalence studies show that picky eating can be as high as 50%. That means they're telling from every 100 children you're picking up, 50 are going to be picky eaters. And that's really stressful. And but if you're using a stringent definition, they say around 5 to 14% is the level of picky eating. But then that is also a big percentage, I would say. Why it is important? Because we know in Kerala, we have tackled under 5 mortality rate very well by controlling pneumonia and diarrhea. And we have actually reached a single digit IMR. And we are having a lot of policies for rehabilitating the disabled now, so that all these will contribute to the increased GDP of the country as well as promoting good citizens for the country. So the next highlight is on having good citizens by intervening in the first 1,000 days of life, that you all know. So the first 1,000 days is the main point where you can hit hard and get good citizens out of it. And there are a lot of nutrition policies, IYCN, development monitoring policies, etc., guidelines, etc., which help us to actually improve the condition. But nutrition is the most important thing, and IYCN may not have the full effect if there is a prevalence of, say, 35 to 50% of picky eaters in the community. So to the guidelines to work effectively, you can just say this much meals, this much frequency, etc. If the child is a picky eater, nothing is going to work. So probably they should have a separate guideline, or we should increase the awareness among doctors and the public regarding the picky eating, why it is happening and how to intervene and when to intervene is the best. All those things need to be taken care of. So let's go into our little barbarian, 13-month-old Udit, who's brought by the mother for complaints of resisting feeds at meal times. She's 28 years, working in a bank after 6 months of maternity leave, straight putting the child with a caretaker because she had to work. This is a common scenario nowadays, and she wants to know if there is an appetizer or an energy drink as food substitute. His development and growth is all normal, and the child breastfeeds around 5 times when she's around. On questioning, he's otherwise active and always exploring the environment, and the maid tries to give him purees or blended food most of the time because it's easier relatively. And the mother has been feeling disgusted on even thinking about the mealtime at night. So cartoons help her. This is a very common scenario which can happen even in a pediatrician's place, because in the initial years of settling, even pediatric postgraduates may find similar situations at home. So know about it and try to control it. So it's important that you listen to the session. Prospective grandparents also might benefit. So this is, if you go and tell mom, my son is a very picky eater, then your mother will tell you, oh, it's because you're in a nuclear family. We were in a joint family. We never had such issues. And you are the seventh one, you know. And do you remember anybody having picky eating in our home? No. It's a fault of joint family, they might say. Or sometimes they may say, in my experience, nobody had like that. So these two statements doesn't have much of a role, because joint family need not be different as well. They are also going towards gadgets these days. And this is the most important threat. Now, we all belong to the generation Y and the millennials, and now it's the Z generation, or the generation Z, or the Zoomers. They are digital savvy. So even a young mother will be addicted to social media, or sometimes she may be doing some career related things on the phone, even while breastfeeding. So the IYCN guidelines or any other guidelines stressing on responsive feeding is taking a last seat, probably right from the beginning. So this important factor is going to be a game changer, is my personal opinion also. So they need to be aware that they have to put away the phone. That's very, very important in this avoidance of picky eating in the coming era. So even if this mother is trying to change, putting away the phone and trying to put forward good food for the child would have learned what he saw right from the beginning, and he is going to be a picky eater in future. So it's difficult to change unless you role model the right things to your child right from the beginning. We know picky eating doesn't have much of a definition. A lot of food items are actually resisted, and some are, they just don't want to even experiment it. That is the issue with picky eating. Up to even 30 food items may be rejected by the child. But the good thing about it is, with repetitive administration, they may try a hand at it. But there is another group which is called the problem feeder, where the number of food items rejected is lesser, around 20, but they don't have the opportunity, they don't give the opportunity to reintroducing the food at all. And they don't try new items at all, even after repetitive administration. And that is a real problem feeder. So we are talking about picky eaters now. So picky eating is actually more common. Around a third of the toddlers are actually suffering from picky eating. And people say they get over it. It's actually an evolutionary thing, they say, because to avoid noxious things from the environment, the child is restricting. That could be a reason. That's the thought in a way. But the thing is, even though people tell that they get over picky eating by around 5 to 6 years, actually only 35 to 50% is getting over. What happens to the rest 50%? They are going to track into adulthood. So that is the importance of picky eating. IYCN or such guidelines are not taking full effect. Picky eating could track into adulthood, and it can interfere with growth and development of the child even. And as an adult, the child will be emotionally labile if he is a picky eater. That's what literature says. So when does it occur? Picky eating is most commonly seen in the age group. One is at 6 months, when you try to introduce complementary foods. That is, a cognition, new cognitive experiences are coming in certain age groups. At that age group, picky eating can happen. One is at the introduction at 6 months. Then the child can have this cognitive change at around 12 to 14 months, when there is a flavor change happening. So at 12 to 14, the child will start choosing the flavor. Before that, if you're introducing all sorts of flavors, the child won't be very choosy with the sugary flavor. Otherwise, the child is going to be choosy. So it's important that you expose the child to all sorts of flavors before 12 to 14 months. That is the second age group where you're getting picky eating. Then comes 18 to 36 months, where the child is having self-awareness, control over the environment. The child feels he's important and he wants to execute his power by telling no to the food.
Madam, sorry to interrupt. Are the slides are not moving, madam?
It's not there. No slides are there.
Okay,
You can please
madam,
listen. Thank you. Okay. And then comes 5 to 7 years of age. At 5 to 7 years, what happens? The child is having abstract thinking and all. And at 9 to 11 years, logical thinking comes. So what happens when this cognitive changes are coming? The child is suddenly exposed to this cognitive environment, and the child doesn't want to actually stimulate his senses by tasting new tastes. So whenever we offer a new taste at this particular age, the child tries to reject it. That happens. Or another thing can happen. Either the child can avoid it, or the child can keep continuing. No, I don't want this particular food. I'll have the one which I had yesterday. The child will try to food jag. That is called food jagging. So either way, you can go in for picky eating or food jagging. Both should be prevented at these ages. So it happens at 6 months. Now, then it happens at 12 to 14 months. Then that is flavor change. Then you have 18 to 36 months where there is self-awareness. And that is the age we are covering now, picky eating in toddlers. You know why? After 6 years, around 6 years, it is so very tough to intervene with picky eater. So it's important that you know that to know why it is happening and try to intervene at the earliest. Even after that, you can intervene, but it is difficult to manage. So know about it and try to intervene. So I told about the importance already, and why does it occur is the next before that. Okay, it occurs more in girls and in elite families and in developed countries. Developing countries, they don't have enough food, so less chance of picky eating. They'll eat anything they get. Okay, this is an interesting picture which shows, see, around 2 to 4 years, you can see that there is a low growth velocity. And at that time, there is a physiological anorexia also setting in, because that is the growth velocity is less. But at the topmost portion, you can see the line, the picky eating habit and the BMR are actually peaking at the same age, that is 2 to 3 years. So why the BMR is still high at 2 to 3 years? Elizabeth Madam beautifully explained to us that the brain development and other organ system developments are actually raising at that age. It's at the topmost level. They're trying to catch up at 2 to 3 years. So the BMR is still high, but the child is having a physiological anorexia, plus the picky eating, the thought of self-awareness. I'm important. I want to stress my importance in the family. They'll say no. So that is the point. Before that itself, if possible, you should intervene and avoid picky eating. So you need to know the age groups. And why does it occur? Whatever happens, why does it occur? In the your mother will be telling Jaisa ba, Vaisa bacha. That is one answer. So does heredity have a role? Yes, says literature. So many twin studies and other literature says that you can actually have dyads of parents and children going in for choosing the same thing. And another important thing is actually there could be actually, if the mother is exposed to a lot of flavors during the prenatal period, you should know about the taste development. The child is actually tasting the flavors inside the womb. When does the taste buds develop? It develops as early as 2 weeks of age, and it's got brain connections even, but the taste pores are not open. So the taste pores open at 16 weeks of life. And at that time itself, swallowing happens. So swallowing is of the amniotic fluid, which is salty. So that is the child's first taste, salty taste. Along with that, whatever the mother is taking, the flavors in a diluted form is reaching the baby. And after delivery, what is happening? The child is on breastfeeding. So the breast milk also has got flavors, what the mother is having, in addition to the sugar in it. So what is the difference between a breastfed baby and a artificial milk baby? In formula also there is sweet flavor, but along with that, there is no other nutritive flavors coming up. So the baby is not exposed to any sort of flavors if it is formula fed. And there are literature definitely proves that breastfed babies are choosing all sorts of flavors in addition to sugar after 6 months when complementary feeds are introduced when compared to formula feeds. And there are rat studies. Animal studies are not possible of that sort. Rat studies which show that if you're exposing the mother to prenatally, just before delivery, to a lot of sugar load, the babies are actually choosing sugar after 6 months of age. So all these show that there is a choice coming up for the baby. And this particular picture I put earlier is a very important thing to control, because this is going to hinder with the child's food. Okay, these are some references which I put, which I have already talked about, and I'll skip it. Actually, want of time is there. All these I have mentioned, and something about the taste buds also I mentioned. And now you have to understand that all the guidelines now say, Madam also told just before, that there should be no added sugars or salt in the child's diet if it is a complementary food. So in family pot diet, all these can be present in regulated amounts. It's healthy diet you're meaning. So in complementary foods, if you're preparing, no added salt or sugar. It can be natural sugars like fruit sugars, that is fine. But added salt or sugar is not advised. That is with all the guidelines available. And what are the types of picky eaters? Now you have the veggie hater. You have the one color kid. Only one color of vegetables he will choose. The other things he won't touch. The fast food fiend, which is very common nowadays, especially in the corona times, when we ask the history, usually the child will go to school and there is not much of feeding happening. It will be regulated by the child himself. But now what mothers feel is that the child is studying in front of the computer. She's going on feeding. Oh, I should give my child something at this time. No, she'll cook something and she'll feed. And the child naturally chooses these things. And there is a lot of swigging and all. So this is a very common cause of obesity also, a dangerous picky eater. Then the separatist you have. That is, they don't want any food items to touch each other. They want it all separate. That is another type of picky eating. And then you have the carbo loader and the texture tyrant. What is texture tyrant? The mother will teach the blended form and the child won't come out of the skill level. I'll come to the skill level in a minute. Then you have the stuck in a rut child. Every day I have the same item. I'll take a lot of time and I'll stick with it and sit with it and slowly I'll finish it. He doesn't like food times at all. And the no fruit kid is also there. Usually you see all these complaints, no? So what is the solution? Probably because of lack of time, I'm going to couple all the tips together and tell you. So first of all, any mother who comes with a complaint is stressed. You have to tell this is a developmental stage which needs active intervention, and she has to be positive and patient. And there is no need to stress that the baby is wasting food or not having a meal. The baby will regulate. She should be counseled that it is the duty of the parents to bring the healthy food at a healthy time to the table. The child is the one who is going to choose whether to eat, what to eat, and how much to eat. So we may get a shock. Oh my God, the child is not having, what is the doctor telling like that? The thing is, even if the child is not going to miss a meal, that is fine with it. The child should know how to regulate according to his appetite. So the mother needs a good counseling and de-stress from you. And then the parenting styles, there are different types, you know. One is the authoritarian parenting style, which is very punitive. And then you have the indulgent type, where the mother is very sensitive to the child's needs, and they will actually understand and give everything. That is sort of pampering. So in between, that loses the parenting structure. That is the issue with indulgent parenting. Then you have the authoritative parenting, which is actually the best one, which is a combination of these two, where the mother will be sensitive to the child's needs. She will understand what is needed for the child, give it the healthy way. There'll be a structure, the regular meal plan, meal time, etc. So that is what is implied in responsive feeding in the IYCN guidelines. And now there is a new concept called baby-led weaning, where the child is offered various foods of different textures, and depending on his skill level, he will choose which to eat and not. So what is skill level? I'll tell now. So that is also being practiced in the West, and probably it may come in the guidelines as well. It is a bit of an extension of responsive feeding. Here, it is happening at the weaning stage itself, where the food is being offered and baby will choose what to have. Baby will experiment with the texture, etc. And I want to stress, I've been talking about the mother. This has to change. Just like the father is promoted in the birthing place to be with the mother, just like the father or even the grandmother or any relative is promoted with breastfeeding and kangaroo mother care, just like that, you need to have the father to involve in responsive feeding. So probably IYCN guidelines should mention and underline it, that both the parents, in today's scenario, both the parents are actually working. They both will be working. And so both of them has got a role to share the responsibility of responsive feeding as well, is my thought. And the child should definitely see that they are having a family meal, and they can take turns offering the same family food in a healthy way to the child, so that the concepts are getting concrete, because both the parents are offering the same thing, and it'll be a very good time if you're taking turns. And size of the plate should be a baby plate only. Don't try to feed the child in an adult plate and put more. Put only baby sized portions. Portions I'll come to now. So every time the mother is feeding, you have to wash the hands, even if it is breastfeeding. The child is watching you. Lot of synapses are forming. So with that, the child will understand with each feed, even during complementary feeding, even if the child is not having anything meaningful, the child should be kept there in a good posture after washing hands. And that washing hands will be learned by the child. And good feeding behavior is a must, and the environment. What is for dinner today? Father asks, and the mother tells, dosha. Oh, same dosha today. That expression, the child will soon pick up. So don't allow the child to have that. Even if you don't like dosha, 2 years only, this habit has to be formed, no? So both the parents have a role in promoting it. So what should the father say? Even if he is bugged with no variety, he should say, oh, dosha, today I'm going to have it with my boy. Like that, he has to tell. He has to act for 2 weeks, 2 years time, because it's the formative time. It is very important. And suppose if your child is already a picky eater, what can you do? You have to change the environment completely. Probably you can give us different plates and put different placemats even, because the previous plate will give child memory. Oh, when this plate comes, I have to say no. So you have to change it. You can even tell, today we are taking off the no plate and bringing in a new plate for baby. Like that, the mother should always keep on telling positive statements. That is very, very important. And she should be very positive to the baby. Even if the baby is not taking, she should not feel depressed. And they can even keep a learning plate. You know what is a learning plate? You can keep a separate plate there and tell the baby, oh, I'm serving this. You don't want it? You put it in the learning plate. What do you need? At least one food item you make sure that the baby likes from the 5 food groups. And a baby will have what he likes. All the rest, the baby has to take and put it in the learning plate. With that, he's actually touching the food. He's experimenting with the food. And then you can even bring a separate bowl for the baby, where the baby after food has to take up from the learning plate, put it in his mouth and spit it into the bowl, the waste bowl. So you know that the food is going waste. Don't panic, but you are climbing up the ladder of skills, where the baby is actually touching, experimenting with the texture, putting it in the mouth, smelling it and tasting it even. So you're higher up in the ladder. And one fine day you can probably ask, today we are going to take a small bite from the learning plate and then chew it and eat. Mama is going to do that. Are you giving me company? You can make it a playtime actually. And then the rest can be discarded. Don't pressurize the baby to have it full. And the theme of today is start right and smart. So probably this talk, though it is not nutrition science, this is very, very important for all the young pediatricians out here. You have to start right and smart with the complementary feeding. You know why? Because till about 6 weeks time, it is appetite driven feeding for the baby. It is only 6 weeks time, mind you. And from 6 weeks to 6 months time, it's based on some reflexes, feeding reflexes. So after 6 months, it's all learned behavior. So even if it is heredity bad, everything is bad, non-contributory, from 6 months, if you intervene, definitely it's going to help. So that is the importance. And what you have to teach is at 6 months, the tongue thrust goes. What is tongue thrust? The tongue will be thrust in a sucking movement till 6 months. After that, it goes away so that a spoon will go into the mouth without being thrust out. Initially, it may go out, but you can make the baby practice it around that time. That is why complementary feeding is started at 6 months, not only because of the calorie difference, energy gap. This is also one particular reason, the developmental maturity of the child with losing of tongue thrust. And after that, you have to teach the baby by around 8 months. You can make funny faces and show the baby about how to make the food go back into the chewing area. The baby doesn't need actually teeth to chew. The gums are good enough. Actually, they are with only one teeth. How can you chew a carrot? No, it is not possible. But with chewing happens in the back at the molar area. So what happens is that you should teach the child you should make the tongue tip to lateralize. So you put the food on the tongue, lateralize it and throw it back towards the thing. You can show it by putting, and baby will watch your mouth very intently and he will try to imitate it. And at that time, after he learns that skill, you can put lumpy foods. And by around 10 months, finger foods can be given, as madam was telling. It's actually a bit harder food, like small finger foods can be offered. For that, the baby should know to chew. So at that time, you can, rotatory chewing comes for the baby. So only if the skills are actually, you take active interest, the baby will learn. For that, the mother need not sit full day with the baby. The mother can work, but whenever she is sitting with the baby, she should be actively, however much tired she is, she should be actively involved with the baby, and she should be teaching the baby with all sorts of funny faces. And you can make the baby interact with the food. You can ask the baby, is this potato mash looking like cloud, or does it look like snow? So it is actually communication. The development will be better. The child will communicate better later on. And most important is the position of the baby. It should follow a 90-90-90 rule.
Nisha, Dr. Nisha? 5 minutes
Yes?
more. 5 minutes more.
Okay.
Okay.
Yes, sir. So
5 minutes more.
the baby has to see, touch, smell, feel, and then only baby will put in the mouth and chew and swallow. So try to make that, don't feel that it's going a waste. Make the baby, put it in the mouth and spit it at least. Okay. So that is the ladder. You're going higher up when you're making him experiment. And this is the 90-90-90 rule. The baby has to touch his feet on the ground if possible. For a toddler, if you're offering a toddler table, family meals may not be possible.
Is it stuck?
Nisha madam? I think she may be having some connectivity issue.
We'll wait for 2 minutes.
Anant, shall we move on, or is she rejoining? Do you get her?
Madam, she is rejoining. Atira madam, she's still not there. I think we can start the next
Yes.
topic.
So Nisha, no, Nisha has joined. Make her co-host also. Make Nisha, Dr. Nisha co-host.
I will make sir. Nisha madam, you are co-host now. You can start the game.
I'm muted. I'm sorry. Sorry for the interruption. I'll finish fast. Probably I'll skip through. Yeah. And so you have to have variety, and you should prevent food jagging. I told the child will choose the same things during the cognitive shift period. Positive words are very important. Sequencing, I'm skipping now. Funny faces you have to make, and teach the child all the skills needed in that particular age, that is 8 months, 11 months time. If that is done by 12 to 14 months, all flavors experimented, very unlikely the child is going to be a picky eater. So start early, smart, be smart. And interesting shapes you saw, you can put fruits and vegetables into skewers and give, so that fruit offered won't go in. This will go in very easily. And you can have family meal every day, persist, ignore the waste. And a rule of thumb is 1 tablespoon per year of the main food, like grain or protein. You can rotate it. To avoid food jagging, you should not repeat the same item the same day and the next day. You can give it on the 3rd day. So you should have 10 items if it is 5 meals on an average on a day. And the most important thing is, you should engage your kid. You should be a good role model and be patient, and don't discuss any stressful news on the table. You know why? On the table, you are trying to put the child calm and learn the manners. But if you're discussing the family issues or payment of EMI, etc., the child will think something is serious, and his adrenaline will go up, which will make him in a react mode. How do he react? He actually react by saying no to food. So can we try to prevent it? Yes. Good eating in pregnancy, during lactation, by teaching to understanding that eating is not instinctive, it is a learned process. All these things can help. Otherwise, you'll be generating what is known as a problem eater or an ARFID. That is, it's absolute restrictive food intake disorder. And in COVID times, without COVID, we can't stop a talk. Actually, in COVID times, there have been many studies saying that junk foods are the favorites of these picky eaters, and unprecedented grocery shortages, especially in ARFID children, is happening. So how to tame our barbarian? You know what happened with him already? You have to de-stress the parent, counsel the parent, and the dictum is parents' role is to bring healthy food for children and set meal times and environment. The child will decide whether to eat, how much to eat, and what to eat. Time spent with family, the position of the baby, the 90-90-90 rule, and slowly advance the skill levels as I showed, and everything you can do. And probably Udit will be having this plate emptied very soon. Thank you all.
Thank you, Dr. Nisha. As Jayaraman sir has said in the chat box that she has done this in a very short period of 2 to 3 days. Only 2-3 days before only she was informed. That was an awesome presentation. I think there is one question about the 90-90-90. Just can you explain that? 90.
I couldn't actually explain. At that time, my connectivity got lost. The thing is that at the hip level, at the knee level, and at the ankle level, it should be 90 degree. So for the child to be erect, you should have that belt on with the booster seat. And at the knee level, if you're putting a stool under the feet, both these angles will be 90. That is the most favorable position, because otherwise, if the feet is dangling down, what happens is the child will be depending on a score to support himself, and he'll feel insecure in his mind. We may not feel it, but the point is the child is supporting. So he's actually concentrating on the core also and not fully looking at the food with interest. So he should not stoop down like this to get the support. He should have his hands free. For that, the best position is this. Just like you have positions for even, I'm not mentioning it now. It's okay. It's food time. Fine. That's the 90-90-90 rule. Any other doubts?
Thank you, Nisha.
Thank you, sir.
So due to lack of time, there's comments from Somashega sir and ma'am from the chat box.
It was a very interesting and lucid. It was a very interesting and lucid talk by Dr. Nisha. The 20 to 25% of our children are normally experiencing the picky eating behaviors.
Yeah.
It is often fun to the child, but it is a fuss to the parents. But only thing we need to look at the red flags. When the picky eating has become very severe, one should have associated autism spectrum disorders that we need to look at. That is a red flag.
May I intervene a bit? There are actually many red flags. Actually, I skipped that slide because of want of time. Probably we'll discuss it in the Wayanad session because it's only 15 minutes. As a pediatrician, when a picky eater comes to you, you will be first ruling out all the organic causes. And then only you will actually assume it's picky eating. So I thought this is a session which is both for pediatricians as well as for a prospective parent or grandparent. That is why I skipped the red flag slide. I'll be discussing it later on, sir. Thank you, sir. Thank you for the input.
Thank you, Nisha. Now over to Dr. Adria.
Thank you, Dr. Nisha and Dr. Balajanta. It was a very nice talk. Thank you all. We'll move on to the next session due to the lack of time. The next talk, starting from the start, that is breastfeeding, maternal concerns and solutions. And the faculty for today is Dr. Priya Srinivasan. The chairperson is Dr. T.V. Ravi. Dr. T.V. Ravi is the president NNF Kerala and president IMA Cochin. He is the HOD of Advanced Neonatal and Pediatric Tertiary Care Center at Ernakulam Medical Center. Over to you, sir, to chair the session and also to introduce the speaker.
Good afternoon, ladies and gentlemen. At the outset, I wish to congratulate IAP Palakkad, IAP Kerala, and Nutrition Chapter of IAP Kerala for organizing such a useful webinar, the Kerala PEDNUTRICON 21. The theme, Feeding Smart right from the start, is most relevant to breastfeeding, in which we advocate breastfeeding soon after birth at the earliest. Though we are striving to achieve maximum compliance with exclusive breastfeeding, it's disheartening to learn that the current compliance level has declined to a mere 55%, while we had achieved up to 90% earlier. This drop could be due to the genuine practical problems faced by working mothers, probably due to lack of motivation, focus, and above all, the time to breastfeed the babies. I'm sure the ongoing project of IAP, along with the government of Kerala, to revive MBFHI will pave way to achieve our goal in future. I am delighted to introduce Dr. Priya Srinivasan, who will speak to us on breastfeeding, the maternal concerns and solutions. She is the Associate Professor of Pediatrics, Government Medical College, Trivandrum. She is a clinical epidemiologist and a PhD scholar. She is IYCF trainer and principal investigator of nutritional assessment in child home study of Government of Kerala. She has co-authored various chapters in nutrition, along with Professor K. Elizabeth Madam in textbooks of Professor Parthasarathi. She was the Secretary IAP Trivandrum 2020. Before I hand over to Dr. Priya Srinivasan, let me thank the organizers for having me here. Over to Dr. Priya. Please unmute.
Thank you, sir, for that nice introduction. I thank the organizers for giving me this opportunity. Yes, so it's already lunchtime and I'll rush through the topic, which is breastfeeding, maternal concerns and solutions. Before going on to the individual maternal the concerns, we'll see the bigger picture, that is the statewide concern regarding the breastfeeding status. That is in NFHS 5, which came out in 2019-2020. The Kerala data shows that the breastfeeding, exclusive that is this early initiation of breastfeeding within 1 hour of birth is happening only to the tune of 66%. And babies under 6 months who are exclusively breastfed in Kerala is only to the tune of 55%. So this is the status in Kerala now. Now, Elizabeth Madam was talking.
Sorry to interrupt. Are you sharing your screen now?
Yes.
No, it's not being shared.
Has it come?
No.
Can you see?
No, it is not.
Okay. Once more I'll do. Now has it come?
Yes, it's visible now.
Okay. Okay. Now, regarding this early initiation of breastfeeding within 1 hour, it will not happen just like that. So we have to set the scene actually. So in the antenatal period itself, we have to prime the mother. We have to show this picture, we have to show that is just after delivery, what is going to happen. The baby will be put prone onto the mother's bare chest so that the mother should understand and the mother should be primed for that event. And during labor, again, we have to set the scene. That is, the mother should be made comfortable. The mother need not be, we need not ask the mother to lay over her back flat for a long period of time. And just before active labor, she can walk around, she can stand, she can sit. So she should be comfortable. Only then this early initiation will happen. And regarding the oral fluids and all, the mother can take clear fluids. And what they say is that that is 2 hours prior to a cesarean section even, mother can take clear fluids so that will prevent dehydration and it will be all set for an early initiation of breastfeeding. And nowadays what they say is that a birth companion of mother's choice can also be allowed inside the delivery room, and that will relieve the stress and the mother will be relaxed for because of her birth companion. And the mother, Elizabeth Madam has beautifully described the navarasas, that is the navarasas of a newly born baby. And we should know that this baby will be alert for 40 minutes. And after that, the baby will go for sleep. So within that 40 minutes, that should be taken into advantage. So that is why the baby should not be taken away from the mother. The baby should be just after delivery. The baby should be put prone on the mother's bare chest so that we should practice. We should start practicing that because after that 40 minutes, so after 40 minutes means after the placental expulsion, after the episiotomy, suturing, all those things. So that precious 40 minutes will be lost. So yearly uninterrupted skin to skin contact is very, very important. Even if the baby is taking only very little milk or the baby is not getting attached, that skin to skin contact which is happening during that first 40 minutes is very, very important. And it will help to develop that bonding in the baby as well as the mother, and the mother milk secretion starts with that bonding, and the baby's temperature gets regulated, the heart rate gets regulated, the respiration becomes regulated. So all these are important. And there is an oxytocin surge as well. Because of that, there will be a uterine involution will be there, and the placental expulsion will occur in a timely manner. So all this is possible because of the skin to skin contact. And the maternal flora will stimulate the baby's immune system, and as early as possible this gets stimulated so that the baby will not develop an early onset sepsis. So these are all the advantages of this very early uninterrupted skin to skin contact. So that should happen. And by that time, before 40 minutes, the baby slowly after 30 minutes, all that 9 activities. So the 7th activity is actually that feeding. So that will happen by, say, after 30 minutes, and by 40 minutes, the baby will go to sleep. So this is all an approximation. And what WHO tells us that this early initiation of breastfeeding, if it doesn't happen, and after 2 hours, the baby is breastfed, that is 2 to 23 hours means the risk of neonatal mortality within 28 days is going to be 1.3 times. And if after 24 hours, the baby is put to breastfeed first time, what happens is the risk of neonatal mortality within 28 days is going to be 2 times. So that is the importance. So early onset sepsis, all these can be prevented with the skin to skin contact. And for this, we should have a dedicated staff. It should be available. Dedicated staff support should be there. And this understanding physiology, now this was also dealt with by Elizabeth Madam. She has made my job easier. That is the stage 1, you have the 16 to 20 weeks of gestation colostrum coming out. And again, the stomach capacity is only to the size of a cherry. So just now, this is just a depiction of the spoonful of colostrum. That is just a 5 ml of colostrum. Whenever it comes, that is say every 2 hours or every 3 hours, just a spoonful of colostrum is enough on day 1 and day 2. And by day 3, that is just by 30 or 40 hours, a copious amounts of milk secretion will start to come. And by day 3, we know that the stomach capacity is that of a walnut. So you can teach all these things to the mother. And from day 3 onwards, once this stage 2 starts, there will be a maternal perception of fullness of breast. So that you can ask the mother, and you can make sure that lactogenesis 2 has set in. And another important point which we doctors should understand is that we need not blame always, we need not blame the mother or the grandmother, or we not just whenever they say milk is not coming. So we also need to be aware that there is a situation called delayed lactogenesis too. 15% can have a delayed lactogenesis, that is well beyond 3 days or even after 5 days. So that is delayed lactogenesis too. It occurs in preterm, that is preterm babies, primary mothers, cesarean sections, and conditions like obesity, if the mother is obese, hypertensive, diabetic, hypothyroidism, pain, stress, and even a long stage of labor too, and delaying early initiation of breastfeeding, which is actually what we should do. And there is something called a failed lactogenesis also. Primary is very, very rare, like some anatomical problems with the breast and all. But secondary failed lactogenesis, that occurs in 5% purely due to extrinsic factors. That is, again, we should intervene because of a poor sucker, poor latch. If the schedule is like infrequent schedule, if we use pacifiers, formula feed supplements, all these, if they are introduced, so it can result in a failed lactation. So lactogenesis too. So that also it is highly preventable. So that we should take into account. And now we'll go into the maternal concerns proper. Now I'll be taking into just only a few very common maternal concerns. The first one, which we hear daily in 40% of mothers, is I am a cesarean mom. So that is the major concern. Then comes not enough milk, and the baby is crying too often, too hungry, and just the opposite. My baby is always sleeping. And then a baby refusing feeds. The baby is not interested in feeds. Then it hurts or it's painful. Breastfeeding process is painful. And in this COVID pandemic, the maternal concern is I am COVID positive, or I took COVID vaccine, what to do, whether to breastfeed. So regarding a cesarean mother, we should understand, we should understand the maternal perspective as well. Like the mother is stressed because of, and she's frightened because of the operative procedure. She's exhausted and she thinks that she should be confined to the bed. And here comes the role of support. So we should support them. And skin to skin contact, so that is not different in a cesarean section. Again, even during cesarean, once the baby has been delivered, the baby can be kept on. The skin to skin contact should occur. The baby should be kept on the mother's bare chest. So that is important. And bedding in, and after in the post-operative period, there should be a supervised bedding in should happen. And that will help in the reflexes to set in. And early ambulation, the mother need not be confined to bed, and within 24 hours, the mother can be made to ambulate. And regarding the posture pain, it should be addressed. And there can be a delayed lactogenesis too. That is part of physiology. So you should not delay early initiation of breastfeeding. So that is one of the reasons for the delayed lactogenesis too. And some matters we do not have a say, like medication. Sometimes the baby may be having a respiratory distress and will be taken away from the mother. So let it so happen. And the schedule, it can be an unwarranted, infrequent scheduling and all because of the cesarean. Again, that we should intervene. We should support. We should give special attention to that. And positioning is also, you need not always have that cradle or the cross cradle position. You can have this laid back. That is what is shown in the picture. So laid back position. And the positions which are shown in circles, that is lying on one side, that can be adopted, or a football hold position, so that the sutures, it will not affect the sutures, will not be painful. So that position, or the underarm position, and the laid back position, all these positions can be tried initially. Now, the next, the common concern is not enough milk. So first of all, you should make sure that the mother's perception is true. That is, you have to ask whether the baby is passing urine sufficiently, that is at least 6 times, and stool at least 2 times. The baby is sleeping peacefully for 1.5 or 2 hours. There is a milk letdown reflex on the opposite. So all these things, opposite breast milk is dripping, all these things you are supposed to ask. And if everything is okay, and then you think that there is not enough milk, then you should teach the mother that actually the cherry, walnut, apricot, all these you should tell, because the stomach capacity, the mother may think that the baby requires so much feed. So that you should tell the volume of feed on day till day 3 and so on. And you should observe the mother feeding. That is very important. That is observe for 4 minutes. That is what the golden 4 minutes. Positioning of the mother as well as the positioning of the baby, it should be comfortable to the mother and the baby. And the attachment is important. That is how the baby latches. That is actually the most important part. That is, should not latch to the nipple. It should be to the areola. And a minimum of 8 feeds, at least 20 minutes per feed. That is all an approximation, but at least 20 minutes. And the night feed should also, because the hormonal influences will set in the cues. The mother should, the hunger cues, the mother should understand. Maternal diet and hydration. Actually, the best galactagogue is water. So that is important. And the mother should be in a stress-free, pain-free state. And for that matter, we should have the whole family should be involved. And there comes the importance of this logo, the World Breastfeeding Week logo. That is a shared responsibility, has been stressed this year. And this is the picture. Madam has also shown the picture. That is the attachment. This is how we should attach. Now you can see that red circle, that is called the contact point or the C point. And that is how it is the sequential picture which shows the attachment. And once attached, the mouth should be wide open. The lower lip should be everted and the chin should touch the breast. So the lower part of the areola should not be visible. And this is the latch score, which should be done in all hospitals where deliveries are conducted. That is the hold or the position is important, how the baby latches, how the baby, there is an audible swallow or not, the type of nipple is important, and whether the mother is comfortable. And 9 and 10 means it is a successful feeding. And less than 7 means you have to intervene. You have to look at the individual. If there is a lower score, you have to intervene according to the score. And another major complaint is the baby cries often, too hungry. Now here again, madam has told that earlier it was the fixed feeding schedule we were promoting, like 2 hourly you feed. Then came the demand feeding. That is whenever the baby cries, you feed. Now it is a responsive feeding. That is, do not make the baby cry. That is a late cue. And you have to understand, make the mother understand the early cues. And even before the baby cries, try to understand the early cues and make the baby should be fed. And sometimes the baby may be crying because it's a short feed. The baby will be getting, the mother will be feeding only for 5 minutes or for 7 minutes. So in that case, the baby is getting only the fore milk and not the hind milk. And so the baby is not getting any satiety. So that should also be taken into account. So tell her that you have to feed sufficiently long. Both the hind milk is also important for the baby to develop satiety. And you should also tell that the baby is not crying for feeds. Baby may be crying for so many other reasons as well, like wet nappies. Baby may be feeling cold, feeling hot, maybe frustrated, maybe requires a little cuddling. So that all these are important. And the mother needs to, regarding this, always sleeping. So baby is not interested, baby is always sleeping. So here the mother should be told that it's not always a pathology, but 16 hours or so a newborn babies may sleep. So that physiology also the mother should know. And some of the babies may be refusing feed. So why refusing? So it may be a benign situation like a nose block where you can give some saline drops, or the baby may be sick. So you have to look for the IMNCA danger signs and all. And sometimes it may be due to an inverted nipple. So that may be the reason for refusal. And here we should understand that the nipple was much hyped, as madam told. Now it is the areola as well as the nipple is one single unit. You need not concentrate more on those in this nipple. And antenatally you can wait. That is no need for any stimulation, no need of any test or something. So just reassure the mother, and just after delivery you can do the areola feeding. That is, it is not the nipple feeding which we usually do in all babies. It is the areola feeding. So it is the usual latch, a deeper latch if possible. So a deeper latch if possible. And you can try the underarm or the football position, because you get an even emptying is possible with. So for all quadrants will be emptied with this football or underarm position. And you can try the different holds of the breast, like a U hold or a V hold, which is shown in the picture, C hold or a sandwich hold. So all these may help to a certain extent. And once in a while you can express. So sometimes if all these are not working, means you can try expressing using the breast pump also. And nowadays syringing or the inverted syringe technique and all these are less preferred techniques, which is not used now. And some of the mothers may complain of the baby is gagging because of a big nipple. So again, in this situation, we should know that the baby will grow faster. So it's because of a small mouth, the baby will grow faster, and within 1 or 2 weeks, the baby will be, the mouth will grow fast. So you have to just, for a few days, you may express out the milk and you can give it. And too much milk, sometimes the mothers may complain like too much milk is coming out and a forceful letdown. Here also the baby may gag. So here what we can do is that we can try the side lying position. So in a side lying position, what will happen is that some of these ducts will be compressed so to a certain extent, so that the amount of milk which is coming out may be adjusted. And you can also try the V hold. The mother can do the V hold and you can adjust the flow. And you can probably unlatch the baby 5 minutes or so earlier, so that again the amount of milk can be adjusted. And some of the mothers, their complaint is it hurts. So actually breastfeeding is not at all a painful business. So if it is painful, means there will be something else. So you should look for sore nipples, cracks, engorgement, all these things. So, and all these problems are mainly because of the poor attachment. So just help the mother to attach or to latch properly, correct the latch and continue breastfeeding. That is the dictum. And for sore nipples and cracks, you can apply some hind milk because it has got some fat. So hind milk, and it has got some immune properties also. And paracetamol can be given, and you have to treat. If there is a candidiasis, look for it and treat the candidiasis. You can apply the clotrimazole cream, and because it does not have an oral absorption, it will not harm the baby. And warmth for engorgement, you can apply a warm compress, or you can give a warm shower, and followed by a massage to the back or and breast, and then ask the mother to feed. And following the feed, you can apply a cold compress to tackle the edema part. And you can also, for engorgement, you can use breast pumps. And the football position, what I've told you for mastitis and all, for local collections and all, you can try the football position, so that there will be an even even removal of milk from all the quadrants of the breast. And for mastitis and abscess, you may have to use antibiotics and INT. And this is the last concern. So I'm COVID process. So these COVID issues, and we should understand that WHO recommends mothers with suspected and confirmed COVID-19 should be encouraged to initiate. You can initiate breastfeeding within 1 hour, continue to breastfeed, no problem at all. And all mothers should be counseled that the benefits of breastfeeding substantially outweigh the potential risk of transmission of COVID-19, and it will not transmit through breast milk. And they should be all these things, that is skin to skin contact, the kangaroo mother care, the day and night rooming in, all these should continue as usual. So nothing different in a COVID positive mother. And breastfeeding mothers can get vaccinated, and they can feed as usual. The thing is that if COVID positive, they have to practice the hand hygiene, wash the hands, and place a mask, and the good surface, that is sterile, apply, clean the surface, and all such precautions. That's all. Thank you.
Thank you, Dr. Priya, for that excellent presentation. Very relevant for this time. Ravi, sir, is he here? Ravi, sir.
Thank you very much. Thank you very much, Dr. Priya, for the detailed insight into the problem, practical problem, and giving the practical tips for mothers regarding the problems faced in breastfeeding. I think it will go a long way in promoting breastfeeding, and we will carry on with the MBFHI initiative, which will further improve our statistics from 55 again back to 90%. That is what we aim. Thank you very much. Thanks a lot for this great opportunity.
Thank you, Dr. Priya and Dr. Ravi. And by this, we are coming to the end of this session. Let me extend my gratitude to all the faculty and the chairpersons for making this occasion a success. Now let me invite Dr. Anand to give the formal vote of thanks.
Dr. Johnny, please make Anand the co-host. Dr. Johnny, please. Adira, Anand is not able to unmute, so I think you can go with the order of thanks.
Okay. So I'm not extending this seminar to any more. Let me extend my warm thanks to all the faculty who have been here, all the participants who have been actively participating for this long. It's almost 2 o'clock. So I don't want anyone to go hungry anymore. My sincere thanks to everyone. Thank you, one and all.
So thank you. We'll leave.
Thank you, dear Jayaraman, for giving me the opportunity. I'm just started having food. I developed severe vertigo. Okay. I'm convalescing. Thank you very much. Thank you. We'll meet you. Meet you on Sunday, coming Sunday, next Sunday. Thank you. Thank you.
ജോസാറേ സാർ മ്യൂട്ടഡ് ആണ്. എന്തായാലും ആനന്ദ്, ഡോക്ടർ ശ്രീപ്രസാദ്, ആദ്യമേ വീണ്ടും ഒരു താങ്ക്സ് കൂടി. Okay, I'm leaving. Bye.
Bye-bye. Thank you, Dr. Adira, President Palakkad. Okay, bye-bye.
Bye, sir.
Thank you. Thank you. Thank you.